Welcome to the MEDSURG review, where I help you prepare for your MEDSURG final. The study guide, you can find it on my website, blossomwithjessica.com. So let's talk about the nervous system. And when we're assessing the nervous system, we have various types of neuro assessments. So the first type of assessment is called the Glasgow Coma Scale. And this scale is going to look at things such as eye-opening responses. You're going to be scoring the patient based on how their eyes open. So are they spontaneous? Are they only opening when you are talking to them? Do they only open to pain, like if you do a sternum rub, or do they not open at all? And then they'll get a point for whichever one they fit. The next criteria is the verbal response. So we're looking at, are they oriented to what we're saying, or are they confused? Do they have inappropriate words? Are they incoherent, or do they have none? And again, they're getting points for whichever one of those they hit for. And then we're looking at motor response. So we're looking at, do they obey commands? Do they only have a motor response to localize pain? Do they only withdraw from pain? Do they have flexion to pain? Or do they have extension to pain? Or do they have none? And again, they're getting the points related to which one they score for. So the total for the Glasgow Coma Scale is anywhere from 3 to 15. A score of 1 in each category indicates no performance of the skill. So the lowest is 3. So just remember that it doesn't go to 0. It goes to 3. The next type of assessment is called PERLA, and this is pupils equal, round, reactive to light, and accommodating. We want to remember that the normal pupil size is 3 to 5 millimeters. And the way we're checking this is we're shining a light into the pupil and we're looking to see if they are round, if both sides are equal, if they are, when we say accommodating, do they change size when you shine light, and does both sides do it? That is what we're looking for with that. Then we're looking at color, sensory, motor, and temperature. We're also looking at vital signs. And we want to remember that the level of consciousness is the best indicator of mental status. Also within the nervous system, we can have elevated intracranial pressure. And what we're going to look for with this is something called Cushing's triad. So you can see that right here. Now, the 3 signs of Cushing's triad is going to be hypertension, bradycardia, and a wide pulse pressure. If patients have all 3 of these signs, this is called the Cushing's triad. And this is a sign of elevated intracranial pressure. We also want to look for signs like changes in the level of consciousness, headache, increased blood pressure with widening pulse pressure. That is, a wide pulse pressure is the difference between the diastolic and systolic blood pressure being really far apart and widening. So whatever your top number is, you have 180 up top, which would be very high, right? Hypertension. But on the bottom, say you have something much lower. Like typically when we see 180, we'll also see a high number at the bottom, but it will start, the systolic will start to go up and the diastolic will start to go down and it will become wide. We're also going to look at our nursing interventions. So our priority, most important, so if you get a question about intracranial pressure, is to elevate the head of the bed to 30 degrees to promote drainage from the brain. You also want to keep the body straight. Flexion decreases drainage. You want to maintain proper fluid volumes, set up a quiet environment with minimal sensory stimulation, stool softeners to prevent straining and avoid Valsalva maneuver, and limit suctioning performed. The next type of assessment within the nervous system we can do is the cerebral spinal fluid assessment. We're looking at things like the color of the spinal fluid. We want normal is to be clear and colorless, and we can look for something called halo sign. This is bloody fluid surrounded by a yellow stain when placed on a white backdrop. So you can see this if you drop a drop of the cerebral spinal fluid onto a white backdrop. You'll see a bloody fluid surrounded by a yellow stain called the halo sign. Also labs, so normally cerebral spinal fluid has little protein and glucose with no white blood cells and no red blood cells and no microorganisms. So we want to make sure that it doesn't have those types of things, or else it's abnormal. Pressure, so the normal pressure is 60 to 150, and the normal volume is 125 to 150 milliliters. So within the nervous system, let's do an anatomy and physiology review. So anatomy of the brain. In the brain, we first have the frontal lobe, and this controls our emotions, judgment, controls motor aspects of speech, primary motor cortex for voluntary muscular activation, and Broca's area for speech. We then have something called the parietal lobe, and this receives fibers with sensory information about touch, temperature, and pain from the other side of the body. It is our spatial perception. We then have the temporal lobe. This is where the auditory information comes in and language comprehension. This is where we have Wernicke's area. We then have the occipital lobe, and this is the center for visual information. We have our cerebellum. This is our coordination of muscular function. We also have our brainstem. In here we have the midbrain, the pons, and the medulla. This is where our respiratory and cardiac centers are, our nerve pathways to the brain. Then we have diencephalon. This is our thalamus, subthalamus, and hypothalamus. So our thalamus integrates and relays sensory information from the face, retina, cochlear, and taste receptors. It interprets sensation of touch, pain, and temperature. Then we have our hypothalamus, which is going to control our autonomic nervous system and neuroendocrine system. It maintains body homeostasis, helps regulate body temperature, regulates our appetite, our thirst center, our sleeping cycle, and controls hormone secretion. So let's talk about the autonomic nervous system. So when we talk about autonomic nervous system, there's really two systems within the autonomic nervous system. So we have our sympathetic, which is our fight or flight, and we have our parasympathetic, which is also known as our rest and digest. So when we have our sympathetic nervous system is stimulated and we're in that fight or flight, we're going to have dilated pupils, increased heart rate and respiratory rate, sweating, epinephrine and norepinephrine is secreted, increased blood pressure, constriction of blood, and abdominal arterioles. So what we can think of is what would happen in our body when we were out in the jungle and we see a lion coming towards us. Think about the way your body would feel, that your heart rate would increase, your breathing would increase. All of that is our sympathetic nervous system. When it comes to the parasympathetic nervous system, you're going to have the opposite, which makes it easier to remember. So we're going to instead have constricted pupils, a lower heart rate and respiratory rate, increased peristalsis, so this is our digestion, the food moving through our digestive tract. Acetylcholine will be secreted. We'll have decreased blood pressure and relaxation of the skin and abdominal arterioles. Okay, so let's talk about the cranial nerve assessment and tests. So cranial nerve number 1 is our olfactory. This is our smell. And in order to test this, we'll use something called a smell test. 2 is our optic nerve. This is our visual acuity. To test this, we will look at the pupils. We'll use a Snellen chart to test visual acuity. This is the chart that when you stand away from the wall and you try to read a line of letters. And also check visual fields. Ocular motor is eye movement. You can remember this with the motor. Ocular is eyes, motor is movement. So we're looking at eye function. We're going to look at pupil constriction and extraocular movements. Extraocular movements, these are our cardinal fields. And this is really if you just hold a pen in front of the patient and move it side to side, up and down, getting these kind of going diagonal across and making sure that their eyes can move in all of those directions. We then have trochlear. So this is our eye function. Again, we're looking at those extraocular movements and the inferior abduction. Trigeminal, so this is sensory of the face and chewing. We can have them clench their teeth or light touch. Abductans, this is the eye function. A lot of these are eye function, and again, doing those extraocular movements. Then we look at 7 is the facial. So this is our facial expression. We'll look at facial movement, eye movement, smile, wrinkling forehead. 8 is acoustic. So we're looking at auditory, balance, and posture, hearing, and Romberg's test. So Romberg's test, this is when you have a patient hold their arms out in front of them with their eyes closed. And what you're looking for is to see if one side drifts. And if it does drift, they would fail that test. And then we have glossopharyngeal, so this is the taste. We'll look for the gag reflex. We have the vagus nerve, which is our cardiac and respiratory reflex. We can have them say ah. Spinal accessory, so strength of the trapezius and sternocleidomastoid muscles, so turning their head or lifting their shoulders. And hypoglossial, this is a motor function of the tongue. We can have them stick out their tongue. So one thing to know with this is we can see that 2, 3, 4 all have to do with eye movement. So you can remember those. So if you get a question about which cranial nerve is related to motor functions of the tongue, you already know that it's not 2, 3, 4, and 6 because those all have to do with eyes. Let's talk about CVA and stroke. So our risk factors include diabetes, atherosclerosis, hypertension, cardiac disease, and transient ischemic attacks. There are different types of strokes. So the first one we have is the anterior cerebral stroke. So this is the lower extremity is more involved than the upper extremities and contralateral hemiparesis and sensory deficits. Then we have a posterior cerebral stroke. So contralateral sensory loss, transient contralateral hemiparesis. And then we have a middle cerebral artery stroke. Upper extremity is more involved than the lower extremity in contralateral sensory loss. You probably will not have to remember all 3 of these and how they present. However, 2 things that you should remember are the 2 types of stroke when it comes to hemorrhagic stroke versus ischemic stroke. So an ischemic stroke is due to the blockage of blood flow, which causes an issue with brain tissue perfusion. Hypertension is common in order to maintain brain perfusion distal to the area of the blockage, and we want to avoid suctioning for greater than 10 seconds to avoid increased intracranial pressure. Our nursing intervention and priority is going to be TPA to be given 3 to 4 hours from the onset of signs and symptoms, and it's contraindicated in thrombocytopenia, uncontrolled hypertension, head trauma within the past 3 months, and major surgery in the past 14 days. So the big thing, again, ischemic stroke is that blockage. So there's some type of clot, something that is blocking the blood flow from reaching the brain. Now, a hemorrhagic stroke is going to be due to a bleed. So you're bleeding in the brain due to blood vessel ruptures. Seizures can occur due to high intracranial pressure and dysphagia. And so our nursing interventions are going to be NPO, neuroassessment, prevent activities that increase intracranial pressure or blood pressure, stool softeners, bed rest with body midline, and anticoagulants are contraindicated because they're bleeding. We don't want to increase that bleeding. All right, let's talk about different types of seizures. So the first type of seizure we're going to talk about is epilepsy. So this is a recurrent seizures due to excessive and sudden discharge of cerebral corticoneurons. We then have tonic-clonic grand mal seizures. So the patient is confused and drowsy about the seizure. It's usually 2 to 5 minutes in length. Then patients can have a absence seizure or petit mal seizure. These are brief, no convulsive contractions, and it may be up to 100 times a day. They can also have something called a simple seizure, which is no loss of consciousness, or they can have a complex seizure, so a brief loss of consciousness with psychomotor changes. Now, this will not be NCLEX, but just so you guys know, there is a type of seizure that does not show up on an EEG. So if a patient is having a seizure, but it doesn't show on their EEG, but it truly looks like they're having a seizure, they can have psychological seizures, essentially. Some people call them fake seizures, but they're not fake. They're real to the patient. They just aren't having electrical activity in the brain. And this can actually come from a trauma. It can be a trauma response. Just so you can take that into your practice with you, that, it's real for the patient when they're experiencing it, but that's not on here. You don't need to know that for NCLEX. That's my spiel. Okay, so nursing intervention. So our priority: assist the patient to lie down, position them on their side, maintain a patent airway, because remember our ABCs: airway, breathing, circulation, allow for drainage of secretions, and prevent the tongue from occluding the airway. We want to loosen restrictive clothes, give oxygen as needed, record the time and duration of the seizure, never abruptly stop anti-seizure meds. We want to do good oral care to prevent gingival hyperplasia from phenytoin, and use suction after the seizure. And when a patient has a seizure, during most interventions, do not use a tongue blade and allow free movement in a safe environment. So we went over this in the safe environment section. We know our interventions include putting pads on the bed. Maybe you're putting down an incontinence pad in case they do urinate on themselves. If they're on the floor and having a seizure, you're putting their head in your lap or in your hands so they're not smashing it off the floor. We always want to think about those types of things. Let's talk about Wernicke's encephalopathy. So this is due to low thiamine intake, B1, or from severe alcoholism. And this is usually where we see it in practice, because severe alcoholism can cause low absorption of B1. So signs and symptoms that we're looking for are an altered mental status, ocular motor dysfunction, this is eye movement, and ataxia. So let's talk about multiple sclerosis. So multiple sclerosis is a progressive demyelinating disease of the central nervous system, and it's autoimmune. So you have a neuron, and on your neurons, there's this thing called the myelin sheath. And it goes around the neuron like that. So what happens is the immune system comes in and for whatever reason decides that it wants to fight off this myelin sheet. And when it does that, it interrupts the connections between the neurons. So that's what it means when it's demyelating, because it is breaking down that myelin sheath. So the signs and symptoms for multiple sclerosis are that they're going to have fluctuating exacerbations. This is with most autoimmune disease. There's usually things like flare-ups. It's always not a constant presentation. There could be changes and fluctuations. It's confirmed with a lumbar puncture, and they're looking for elevated gamma globulin. They also might do a CT, MRI, myelogram, or EEG.
These patients can have confusion because the central nervous system can connect to the brain and can have sensory deficits, decreased perception to pain, touch, and temperature. They may have bowel and bladder deficits. They can have spasticity, ataxic gait, weakness, tremors, spasm, paresthesia, vision changes, dysplasia, hyperreflexivia, and a positive Babinski, because we just have to remember all of these are connected through these neurons. Anything that is connected to our central nervous system and our neurons is going to be affected. It just depends what pathway is being attacked at that time. So our nursing interventions, our priority is to protect the patient from injury, assist with frequent bladder and bowel elimination, regular exercise and rest, PT and speech and language may need to be involved, and fluid intake and a low-fat, high-fiber diet. And again, these will be individualized depending on how our patient presents with all of these different symptoms that they could have.
Let's talk about autonomic dysreflexia or hyperreflexia. So this is caused by sympathetic nervous system stimulation after either an injury at the T6 or higher, or a lesion in the high thoracic or cervical cord, or a blockage of the urinary catheter. So signs and symptoms we're going to look for are severe hypertension, sweating above the level of injury or flushing, headaches, bradycardia, piloerection, nausea. Nursing interventions include our priority, so important, is to monitor blood pressure and provide antihypertensive meds if needed. We want to monitor bladder distension, assess for bowel impactation, remove restrictive clothes, and keep the head of the bed at 45 degrees. This is a neurological emergency as it can lead to a hypertensive stroke. All right, now let's talk about meningitis. So this is an inflammation of the meninges of the spinal cord and brain caused by bacteria. So signs and symptoms, we're looking for Brudzinski's sign, which is involuntary flexion of the hip and knee when the knee is flexed. There's also Koenig's sign, which the patient is unable to straighten the leg when it is flexed at the knee and hip. They will have a stiff, tight neck, fever, confusion. Their cerebral spinal fluid will be cloudy with high protein, high white blood cells, and low glucose. Our nursing interventions include the priority is droplet and contact precautions if bacterial, or meningococcal meningitis. We're going to assess for signs of intracranial pressure. We're going to keep the head of the bed at 30 degrees and avoid flexion of the body. We're going to put them on seizure precautions, and we're going to prepare for a lumbar puncture because we want to look at that cerebral spinal fluid. Let's talk about Myasthenia Gravis. So this is a neurological disease characterized by muscular weakness. This is because communications between nerve cells and muscles are impaired due to defective nerve impulses. So our signs and symptoms are that it is a progressive disease, decreased muscle membrane acetylcholine receptors. They have severe weakness proximal more than distal to muscles. Their facial, ocular, and bulbar weakness, dysphagia, vision changes, difficulty breathing, possibly life-threatening as respiratory muscle weakness can happen. And they probable use of anticholinesterase drugs for treatment. So our nursing interventions include our priority is going to be deep breathing and coughing. We also may need to suction and have emergency equipment at the bedside, again, because of that respiratory muscle weakness. We want to prevent aspiration, so keeping them in a high Fowler's, especially when they're eating. We want to time exercise activities for when the patient has maximal muscle strength, so muscles are stronger in the morning and then they get weaker at night. So we want to do most of their kind of exercise and activities in the morning. We'll administer anticholinesterase drugs, and we want to avoid stress. So we're also are going to compare a myasthenia crisis versus a cholinergic crisis.
So let's look at the difference. So with a myasthenia crisis, it is an acute exacerbation of myasthenia gravis, so what we just talked about. So this is an acute exacerbation, whereas a cholinergic crisis is because there's too much acetylcholine due to an over-medication with an anticholinesterase drug. So we can really see a cholinergic crisis in any patient on an anticholinesterase drug. Myasthenia gravis, we're only seeing in those with myasthenia gravis disease for a myasthenia crisis. All right, so let's look at the signs and symptoms. So for myasthenia crisis, our signs and symptoms are tachycardia, increased respiratory rate, hypertension, shortness of breath, cyanosis, bowel and bladder incontinence, decreased urine output, and no cough or swallow reflex. Again, because all those muscles are getting weak. Our signs and symptoms for a cholinergic crisis are cramps, nausea, vomiting, vision changes, pale, muscle twitching, and hypotension. So as we can see, there's actually, these are opposite, right? Because one is having hypertension, the other has hypo. Things that are similar is maybe the cyanosis and pallor. Those are similar. So just some things to keep in mind. But let's look at our nursing interventions. So for myasthenia crisis, our priority is to increase anticholinesterase meds. So we want to increase those. So our nursing priority for a cholinergic crisis is we want to hold the anticholinesterase meds. So again, they're the opposite. And if there is an overdose for cholinergic crisis, the antidote is atropine sulfate. All right, then we have something called an endrofium test. This is used to diagnose myasthenia gravis and differentiate between myasthenia crisis and cholinergic crisis. So to diagnose myasthenia gravis, they'll do the test and it will cause the muscle strength to improve. So when they do this test, endrofium, they're looking to see if muscle strength will improve. For people who have myasthenia gravis, there's going to be no improvement. So it's going to be negative in muscle strength or deterioration in muscle strength. So if we're going to differentiate between myasthenia gravis and cholinergic crisis, if after the endrofium muscle weakness improves, then it's myasthenia gravis, myasthenia crisis. Patient will need more medication. Again, because our priority is to increase those meds. If after administration weakness worsens, then it is a cholinergic crisis. The patient is over-medicated with the anticholinergic meds and needs atropine sulfate. So that's how we can differentiate. Patient is at risk for VFib and cardiac arrest during this test. So keep that in mind. All right, let's talk about Parkinson's disease. So Parkinson's disease is a degenerative disease primarily involved in the basal ganglia. Signs and symptoms we're looking for include bradycardia, resting tremor, monotone speech, impaired postural reflexes, rigidity, loss of inhibitory dopamine, a mask-like affect, drooling and difficulty swallowing, and a shuffled gait. And the ones I underlined are really the ones that when you see a picture of someone with Parkinson's, that's what you're going to really see. Nursing interventions include a soft diet, high in calories, proteins, and fiber. You want to increase fluid intake. Safety measures, are they a fall risk? Implement those safety measures. They might need PT, they might need rehab. We want to avoid foods high in B6 because these can block the effects of some of the medications that we use for Parkinson's disease. And we want to avoid MAOIs because, again, this can have some impairment. It can cause that hypertensive crisis. Bell's palsy, which is recognized as facial paralysis. This is due to lower motor neuron lesion on the C7 that results in paralysis of one side of the face. That's the hallmark sign. Recovery is usually in a couple weeks. It does not affect vision, balance, or extremity motor function. So again, and this can also be a sign of a stroke, right? So that's why we have to do those neuro tests as well. So signs and symptoms, flaccid facial muscle. Nursing interventions include facial muscle exercises, protect the eyes from becoming dry. So we might have to have some artificial tears or wear a patch, provide oral care, and have patients chew on the unaffected side. Then we're going to talk about Guillain-Barré syndrome. So this is a polyneuropathy with progressive muscular weakness. It is an autoimmune disease. It may be triggered by an infection causing neuritis of the cranial and peripheral nerves. You'll also see this is a side effect of some vaccines. It's rare, but it can happen. So signs and symptoms, demyelation of peripheral and cranial nerves, which is similar to MS. MS attacks the myelin sheaths on the central nervous system. Guillain-Barré is the peripheral nervous system. So motor paralysis in ascending pattern. It has a 3% mortality because of respiratory failure, autonomic dysfunction, arrhythmias, blood pressure changes, tachycardia, potential respiratory failure, pain and hypersensitivity. And when they do a cerebral spinal fluid test, they'll see high protein. Next thing we're going to talk about is amyotrophic lateral sclerosis. This is also known as ALS. And this is a degeneration of the motor system with no changes in sensory, autonomic, or mental status. There is no cure. Signs and symptoms include respiratory difficulty at the end of the disease because the respiratory muscles are affected, leading to death, muscle weakness, and dysphagia. Let's now talk about Lou Gehrig's disease. So this is a degenerative disease affecting the upper and lower neurons. Signs and symptoms, usually they have death within 2 to 5 years. You'll see spasticity, hyperreflexia, dysarthria, dysphagia. This is difficulty swallowing. You'll see some autonomic dysfunction in about a third of the patients, but their cognition will remain normal. So different symptoms that we could see for this include Horner's syndrome. So this is the result of another medical condition such as a stroke, tumor, or spinal cord injury. Symptoms include a smaller pupil, drooping eyelid, and little or no sweating on the affective side. We can also have anterior cord syndrome. So this is damage is mainly in the anterior cord, resulting in the loss of motor function and pain and temperature with preservation of a light touch, preoccupation, and position sense. Then we have Brown-Séquard syndrome. So this is a hemisection of the SC resulting in an ipsilateral weakness and loss of position and vibrational sense below the level of the lesion. So this is the spinal cord. I was like, what does that stand for? It's spinal cord. Okay. Basilar skull injury. So signs and symptoms. One main thing that we are looking for is called the battle signs, and this is a bruising behind the ear. Another sign is periorbital hematoma, so raccoon eyes, like 2 black eyes, and cerebral spinal fluid leaking from the nose or ear. Our nursing interventions our priority is to support airway, breathing, circulation. We know that's always our priority. We can do C-spine immobilization. That's when you hold the neck still, don't move the patient, make it so they don't move their neck, and neuromonitoring. All right, so some more on head injuries. We also have concussions. So a concussion happens when there's a jarring of the brain with no loss of consciousness. They might have retrograde amnesia where they can't really remember what happened before or regarding the event. And what we want to do, our intervention, is rest and light diets are encouraged. And then we have a contusion. This is bruising to the brain, can occur with a subdural or extradural blood collecting. We have a skull fracture. An example is linear, depressed, compound, or comminuted. We have epidural hematoma. This is the most serious hematoma. A hematoma forms quickly. So this is the blood is forming inside of the skull. So due to an arterial bleed, it could be the middle meningeal artery. It forms between the skull and the dura mater. there is a loss of consciousness and the patient may then feel better quickly, where they have a lucid interval followed by a quick decline in mental function. We can also have a subdural hematoma. This is a slow bleed from a venous injury. And we can have an intracerebral hemorrhage, which is a blood vessel in the brain ruptures, causing blood to leak inside of the brain. And then we have spinal cord injuries. So this can be a total transection of the cord, would be total loss of sensation, movement, and reflex below the level of the injury. So this is like a complete break. If the injury is between C1 and C8, we can have a quadriplegic. If it's C2 and C3, the injury is usually fatal. And any injury between T1 and L4 can be paraplegia. Any injury C4 or above can lead to respiratory difficulties. So our nursing priorities are going to be, first priority is always assume the spinal cord injury with trauma until it's ruled out. We also want to immobilize the patient on a backboard. Body should be midline with head in neutral position, maintaining a patent airway. We want to log roll the patient if needed to put them onto a stretcher. And again, monitor ABGs to assess respiratory status. And spinal cord immobilization, you'll often hear this called C-spine. You can use this if needed. Again, this is to keep the neck from moving. You're just holding the neck. You're holding the head, keeping the neck. We can do a neuro exam if we're concerned. If there's significant trauma, we want to look at level of consciousness. Are they intoxicated? Do they have another injury? And we can do a spinal exam as well. So let's talk about the respiratory system. So first, let's talk about assessments. So there are different breath sounds that you could potentially hear. So the first is called a friction rub. This is caused by rubbing of the pleural surfaces against one another, usually as the result of an inflammatory process. This is going to sound almost like a kind of rubbing, squeaky noise. Okay, then we have rales, also known as crackles. This is an adventitious breath sound associated with pathology, meaning there's some type of infection, pneumonia, something like that, something that is making the lungs crackle. These rales or crackles could be the result of air bubbles or secretions or movement of fibrotic tissue during breathing. So again, this is going to sound like a crackle. Almost sometimes people say that it sounds like when you rub your hair together. That's the noise you'll hear. Then we have bacillary rales. These are often accompanied by left ventricular congestive heart failure, so electrolysis, fibrosis, and pulmonary edema, and it's related to the opening of previously closed small airways and alveoli. Then we have rhonchi. This is a continuous, that's the key word, continuous, low pitch, sonorous breathing sound that are more prominent during expiration. That's another key thing, prominent during expiration, and could be the result of air passing through the airways narrowed by inflammation, a bronchospasm, or secretions. And again, heard during expiration. That is a key. Then we have stridor. So again, this is a continuous adventitious sound of inspiration. So this is key, inspiration, associated with an upper airway obstruction. So again, you're only hearing the sound when they breathe in. So wheezes, this is a continuous breath sound that are high-pitched and musical. So if you ever see something asking about a musical sound, that's going to be wheezes. And they're often associated with asthma, COPD, and foreign body aspiration. And we should always remember that with our nursing interventions, patients with any type of respiratory disorder should have the head of the bed elevated. All right, so let's talk about risk factors for respiratory disorders. So we have allergies and crowded living conditions, chest injury, exposure to chemicals and environment pollutions, family history of infectious disease, frequent respiratory illnesses, geographical residence and travel to foreign countries, smoking or chewing tobacco, and viral illnesses. So the first chest injury we're going to talk about is called flail chest. So the signs and symptoms are a paradoxical respiration. So this means an inward movement of a segment of the thorax during inspiration with outward movement during expiration. So the way you can think about this is the chest is moving the opposite way you would expect. So typically when people breathe in, their chest expands. When they breathe out, it relaxes, it decreases in size, but this is having the opposite. So you're getting that inward movement that you would usually get when you exhale during an inhale. And then the opposite, when you exhale, you're getting the outward movement. That's a paradoxical respiration, and that's a sign of flailed chest. Severe pain in the chest, dyspnea, cyanosis, tachycardia, tachypnea, hypotension, shallow respirations, and diminished breath sounds. And again, we want to remember that when we're looking through all of these different diagnoses, we want to pick out what are like the key big differences. So for flailed chest, you're going to see those paradoxical respirations. That most likely will be in the question if they're asking about this. So our nursing interventions, these are going to include maintaining the client in Fowler's position. That is usually the answer for anything respiratory related. We want them in Fowler's because when you sit them up to high Fowler's, you're actually pressing the diaphragm a little bit so they can't get as deep of breath. So really the best position to get them in is a Fowler's position. We're going to limit activity, administer oxygen and pain meds, monitor for increased respiratory distress, and encourage coughing and deep breathing. All right, so let's talk about a pneumothorax. So signs and symptoms include absent breath sounds on the affected side. So that is the key for a pneumothorax, something really important to remember, the things we want to pick out. So when you're listening to breath sounds, if you're not hearing sounds on one side, it's because they could have a pneumothorax. You'll also see the cyanosis, decreased chest expansion unilaterally. So because they have a pneumothorax, their chest isn't fully expanding on that side. So you'll also see this is another key point. Dyspnea, hypotension, sharp chest pain, subcutaneous emphysema as evidenced by Creptus on palpation. So if you feel their chest and you're feeling what sounds like cracking, it's air under the skin, and that is another key thing of a pneumothorax. If they have a sucking sound with an open chest wound, that's another, that right there is pretty obvious, right? If there's a hole in their chest. Tachycardia, tachypnea. The other really important thing is tracheal deviation to the unaffected side with a tension pneumothorax. So part of your head to toe assessment, you're looking at the trachea, you're making sure the trachea is midline. If it's not midline, it's pushed over to a side. It could be that they have a tension pneumothorax and it's going to be on the opposite side of the way the trachea is deviated. So again, the deviation is towards the unaffected side. So our nursing interventions are going to include applying a non-porous dressing over the open chest wound. We're going to administer oxygen as prescribed, place them in Fowler's position, prepare for chest tube placement, which will remain in place until the lung has expanded fully. Monitor the chest tube drainage system, and monitor for subcutaneous emphysema. The next thing we're going to talk about is a pulmonary embolism. What you're going to see with these patients, this is a blood clot to the lung. This is a clot in the lung. So you're going to see apprehension and restlessness. They're going to start to have blood-tinged sputum, chest pain, cough, crackles and wheezing on auscultation, cyanosis, distended neck veins, dyspnea accompanied by anginal and pleuritic pain, exacerbated by inspiration. So when they breathe in, it starts to hurt more. Feelings of impending doom. This is a big one that you will see on questions. If they talk about that, patients are feeling there's an impending doom. Sometimes that can indicate a pulmonary emboli. Hypotension, petechiae over the chest and axilla. So that's another kind of specific thing to a pulmonary embolism. Shallow respirations, tachypnea, tachycardia. So our nursing interventions are going to include notifying the rapid response team and healthcare provider, reassess the client and elevate the head of the bed, prepare to administer oxygen, obtain vitals, check lung sounds, prepare to obtain an arterial blood gas, prepare for the administration of heparin therapy or other therapies, and document the event and interventions taken. Right. The next diagnoses we're going to talk about is tuberculosis. So this is an infectious respiratory process caused by tuberculosis bacilli. So the diagnostic tests that we are going to use include APD, which is a purified protein derivative. So this is given as a subcutaneous injection, typically in the forearm. So what we need to remember is that a negative test will be between 0 and 4 millimeters after 48 hours with redness, but without induration. Induration is a bump. A positive induration is going to be anything greater than 15 millimeters in a healthy individual, or 10 millimeters after 48 hours in immunocompromised individuals, or 5 millimeters in high-risk individuals such as those with HIV. A positive test with no symptoms, the patient gets a chest x-ray, and a positive test with symptoms, the patient gets a sputum culture. The next type of test is a sputum plus for myobacterial tuberculosis. So again, this is the sputum culture. So this will happen within 2 to 3 weeks of onset of symptoms, and it will be negative if the disease is in the latent phase. So our treatment is going to be, the drug of choice in most cases is going to be isoniazid or rifampin, and they typically do these together. So treatment will depend on which type the disease is in. So if it's in the latent phase and it's asymptomatic and there'll be no tuberculosis transmission, normal chest x-ray, no sputum needed to be collected. That's fine. Patient's fine. However, if they're in the active phase with cough, fever, chills, weight loss, anorexia, fatigue, TB can be transmitted, have abnormal x-rays and a positive sputum culture. So symptoms, we're going to see fatigue, lethargy, anorexia, weight loss, chills, fever, chest pain. And our nursing interventions are going to be airborne precautions for TB always, because it spreads through the air. So we need the filter on an N95 mask. The room should have 6 air exchanges per hour. And patient is to wear a mask if leaving the room. All right, so asthma. This is airway inflammation that can be caused by hyperresponsiveness to allergens, exercise, or irritants. Signs and symptoms are wheezing, shortness of breath, coughing, or chest tightness. Our nursing interventions, our priority is always keep the airway patent, right? Because our ABCs, airway, breathing, circulation, and then to administer systemic steroids. So what does this mean? This means if you get a question about somebody having an asthma attack, well, systemic steroids, although they work long-term. This is a long-term treatment. So what that means is if they're having an asthma attack, they need a quick treatment. So this is when you would use something like albuterol. Okay, so let's talk about COPD. COPD is an airflow limitation resulting from a small airway disease or parenchymal destruction. So there are 2 types. You have chronic bronchitis and you have emphysema. So we can remember this as chronic bronchitis. These patients tend to look more like blue, where emphysema, they tend to be called red puffers because they're just kind of more red and they have what's called a barrel chest, so they're more round in their shoulder area. But all right, let's go through it. So chronic bronchitis, these people that have a smoking history or cor pulmonale, they have decreased expiratory flow rates, crackles, wheezes, and hypoxemia. For our emphysema patients, these are going to have those barrel chest. So that's like a big one that indicates emphysema. Again, the dyspnea, the cyanosis, they're going to have some clubbing and accessory muscles of ventilation. So our nursing interventions include a normal oxygen SpO2 is going to be 88 to 92, which would be low for a normal person, but that's typically where people with COPD live. So that's okay as long as they're not showing symptoms. We don't want to raise the oxygen level higher than 88 to 92 because a lower SpO2 is what stimulates COPD patients to breathe. So if we turn up the oxygen, their body is not going to make them breathe. So we want to keep them between this 88 and 92. Pneumonia. So pneumonia is an acute inflammation of the lungs due to bacteria, viral, fungal infection leading to stiffening of the lungs. Diagnoses, we would do a sputum culture and sensitivity with confirmation of the organism, and this is how we can figure out which antibiotic to give because we're checking the sensitivity. And aspiration pneumonia results from the inhalation of foreign matter. Signs and symptoms are fever, pleuritic pain, so pain that is sharp and increases during inspiration, tachypnea, wheezing, accessory muscle use with breathing. We can see a changing level of consciousness and sputum production. Our nursing interventions, our priority is going to be droplet precautions. So we always want to remember with pneumonia, we're using droplet precautions. We want to supplement with oxygen, monitor their level of consciousness. We can have them do some deep breathing and coughing, semi-Fowlers to assist with breathing, chest physiotherapy to mobilize secretions, fluid intake to thin secretions, and antibiotics. Then we're going to talk about a pleural effusion. So this is a collection of fluid in the pleural space, preventing lungs from fully expanding. These patients are going to have pleuric pain, shortness of breath, dry cough, tachycardia, fever, and decreased breath sounds over the area. Our nursing interventions include the priority is to prep the patient for a thorough census. We're going to keep the patient in Fowlers, and we're going to monitor for breath sounds. The next diagnosis we're going to talk about is empyema. So this is a collection of pus within the pleural cavity. Our interventions are going to be to treat the infection. So we want to figure out what it is, and we want to give some antibiotics that will treat that type of infection. We want to use high Fowlers, coughing and deep breathing, and a thoracentesis or chest tube for drainage. Let's talk about some respiratory interventions. So first, we have supplemental oxygen delivery devices. So we want to remember these different face masks and cannulas that we can use to deliver oxygen. So the first one is a nasal cannula. This is going to deliver at 1 to 6 liters per minute with a FiO2 of 24 to 44%. And this is for patients on long-term oxygen use or with airflow limitations. Then we have a face mask. This is going to be delivered at 5 to 8 liters per minute with an FiO2 of 40 to 60%. And we want to monitor for risk of aspiration, for short-term oxygen therapy, or for emergencies is when we would use a face mask. Then we have a Venturi mask. So this is 4 to 10 liters per minute with an FiO2 of 24 to 55%. And this is for patients in acute respiratory failure. Venturi mask. Then we have a partial rebreather mask. This is going to be delivered at 6 to 15 liters per minute with an FiO2 of 70 to 90%. We will adjust the flow rate to keep the reserve bag 2/3 full during inspiration. And then we have a non-rebreather where the rate of flow needs to keep the bag full. The FiO2 is 60 to 100%, and this is for patients with deteriorating respiratory status. So then we also want to talk about ventilator alarms. So things to remember with this is a high pressure alarm can be caused by increased secretions, tube kinks, patient biting on the tube or coughing, whereas a low pressure alarm can be caused by tube disconnection or the patient stop breathing. Chest tubes. And with a chest tube, there are 2 different suction types. So we have a wet suction and a dry suction. A wet suction is regulated by the height of water. So we can remember wet, water. in the suction-controlled chamber. The suction-controlled chamber is filled with water, and the amount of suction depends on the height of the water. We want to see bubbling. Bubbling is good. A dry suction, the suction monitor bellow controls the amount of suction, and the amount of suction is controlled by moving the dial on the suction control area. Now, within the suction machine, we have different areas. So we have a drainage chamber. So this is going to monitors drainage, color, and amount. The normal is less than 100 cc's an hour, and it's located right below the tube that comes from the patient. Then we have a water seal chamber. So this again is going to be on our wet section. Water fluctuates with inspiration and expiration, so we want to see it moving up and down as they breathe. If there's no fluctuation, and that means that the lung has re-expanded or there is a kink. Then we have the air leak monitor. So if this has excessive bubbling, it indicates an air leak. And if patient has a pneumothorax, air in the pleural cavity, intermittent bubbling is okay. So what are our nursing interventions? It's going to depend what happens. So if we have dislodgement, we want to cover the area with a sterile dressing, tape 3 sides so that air can escape but not enter. If there's a tubing issue, we want to make sure that the tubing is below the patient's chest, keeping it free from clots, kinks, and stagnant fluid. And during removal, we want to position the patient in semi-Fowlers, perform a Valsalva maneuver, and have them hold their breath. So some medications to remember related to the respiratory system include atropine, so used for severe asthma to help with spasms and involuntary muscles and inhibit secretions. Bronchodilators like epinephrine, alupent, Benetton, Proventil, relax smooth muscles and open the airway. And corticosteroids like prednisone and cortisol are used to decrease edema and inflammation in COPD. So let's talk about the cardiovascular system. So the first thing we're going to talk about is cardiac marker labs. And the first one we're going to talk about is CKMB, or creatinine kinase myocardial muscle. So what this is looking at is if the value is elevated, that means that there has been cardiac damage following an acute ischemic attack. This is usually around 18 hours after an acute ischemic attack. And the normal value is going to be 2 to 6 in males and 2 to 5 in females. The next one we're going to talk about is troponin. So troponin C, cardiac troponin 1, and cardiac troponin T. So troponin 1 is specifically has a high affinity for myocardial tissue. So that's troponin 1. It rises within 3 hours and persists up to 7 to 10 days after myocardial injury. Normal values are typically low, with troponin 1 being less than 0.3 and troponin T being less than 0.2. The next one we're going to talk about is myoglobin. So this is an oxygen-binding protein found in cardiac and muscle cells. The level rises within 2 hours after cellular death, with a rapid decline in the level after 7 hours. However, it is not cardiac specific. Now let's talk about B-type natriuretic peptide, or BNP. This is released in response to atrial and ventricular stretch. It serves as a marker for heart failure. The levels should be less than 100, and the higher the level, the more severe the heart failure. Let's talk about cardiac diagnostic procedures. So the first one is an electrocardiogram. So this is going to record electrical activity of the heart. It detects dysrhythmias, myocardial infarctions, and cardiac hypertrophy. Then we have something called a Holter monitor. So this is a monitor that the client will wear throughout the day over 24 hours or more, and it records the electrocardiogram tracing throughout the entire day. But the patient must avoid hot tubs, baths, and showers because, again, it is electrical. Then we have an echocardiography. This is like an ultrasound. It evaluates the structural and functional changes in the heart. There's something called an exercise electrocardiography test or a stress test. This is done while the patient is on a treadmill. If the patient cannot tolerate the treadmill, testing the patient may be given with an IV medication called So they'll give this IV. The patient doesn't have to get on the treadmill. And it's important to note that the patient should be NPO for 3 to 6 hours before the procedure. And our nursing interventions include instructing the client to avoid smoking, alcohol, and caffeine before the procedure, as these can interfere with the. Then we have a myocardial nuclear perfusion imaging, or an MNPI. This is the use of radionucleotide techniques in scanning for cardiovascular assessment. And then we have a magnetic resonance imaging, or an MRI. And this is going to use radio waves, magnetic fields, and atomic nuclei. It provides information on chamber size, valve, and ventricular function and blood flow. And our nursing interventions include making sure all metal is removed and to assess for claustrophobia. And because this is using magnetic fields, it can actually pull the metal out of a patient. So we just need to make sure that they don't have metal in their body. All right, so the next one we're going to talk about is a cardiac catheterization. And this is an invasive procedure which inserts a catheter into the heart and surrounding vessels. Our nursing interventions include assessing for allergies to seafood. This is a big one. Iodine or radioplaque dyes. This is because when they're doing this, they inject a medication that is similar to seafood, and iodine has the same kind of allergic reaction. If you're allergic to seafood, you'll have an allergic reaction to it. So we need to know that doesn't necessarily mean that they won't get this procedure, but they might need to be pre-medicated or something like that. We have to withhold solid foods for 6 to 8 hours. If the patient is taking metformin, it must be withheld for 24 hours because of the risk for lactic acidosis. Usually held for 48 after the procedure. Post-procedure monitor peripheral pulses, color, warmth, and sensation distal to the insertion site every 30 minutes for the first 2 hours. Apply a compress device or sandbag to the insertion site and monitor for bleeding. Keep the extremity extended for 4 to 6 hours. Maintain bed rest for 6 to 12 hours, and do not elevate the head of the bed more than 15 degrees. So let's talk about cardiovascular disease process. So some keywords to know are atherosclerosis. So this is the development of a fatty area throughout the arteries of the heart. Then we have angina pectoris. So this is a term used to describe chest pain in which the pain is not localized but may include the left arm area as well as the sensation of an inability to breathe and demise. Thrombus. This is a term used to describe a blood clot. Then we have a myocardial infarction. It is used to describe a complete arterial narrowing that does not allow for blood flow to take place. It's also described as a heart attack. Then we have thrombosis. This is the development of a thrombus or clot inside a vessel. And ischemia, which is a decreased supply of blood and oxygen to an area of tissue. So when we talk about angina, and again, this is a term used to describe chest pain in which the pain is not localized. So we can have stable, which is chest pain with exertion or activity relieved with rest or nitro. We can have unstable, which is chest pain that is unpredictable, may or may not be relieved with nitro. And variant or prismals is chest pain due to a coronary artery spasm, and it may occur at rest. So let's talk about a myocardial infarction. Signs and symptoms: patients are going to have chest pain and pressure, diaphoresis, dyspnea, anxiety. Females can present stating that they feel like they have indigestion, shoulder pain, or jaw pain. And one important thing we want to look for is EKG changes. In acute MI, you're going to see an ST elevation in localized leads. So if there's ST elevation, that is a big sign that it is a myocardial infarction. So our nursing interventions, we always want to remember our ABCs. So breathing, circulation, we're doing vital signs. They might need, we want to look at an EKG, but also those cardiac markers that we talked about, because that's going to tell us if there has been tissue death, specifically cardiac tissue death, depending on which marker we're looking at. And they may need nitroglycerin or morphine. Those are the treatments for heart attack. Let's talk about aortic aneurysm. So an aortic aneurysm is an abnormal dilation of the arterial wall. So there's like a bulging of the arterial wall caused by localized weakness and stretching in the medial layer of the wall of the aorta. We want to assess for the main kind of big problem with an aortic aneurysm is that it could burst. And that's any aneurysm, right? We're nervous it's going to burst and then they're going to have bleeding. Signs and symptoms we're looking for are pain, syncope or cyanosis, dyspnea and increased pulse. They might have hoarseness, difficulty swallowing because of the pressure from the aneurysm. All right, so let's talk peripheral artery disease versus coronary artery disease. So peripheral artery disease is a decreased blood flow to the lower extremities due to atherosclerosis. Our signs and symptoms are intermittent claudication, so they're going to present with muscle pain in their extremities. They could have hair loss. So typically we see this on the legs. You're looking from the knees down. They'll typically have some muscle pain, especially when they're moving, hair loss on their legs, decreased peripheral pulses, cool and dry skin, gangrene, thick nails, and ulcers. When we talk about coronary artery disease, this is going to be an obstruction or narrowing of a coronary artery due to atherosclerosis. So one is an obstruction of the coronary artery, and the thing that is nice is this is called coronary artery disease. You know it's the coronary arteries due to atherosclerosis, where the other one is called peripheral arterial disease. So you know that it's not the coronary arteries. So with coronary artery disease, these patients are going to have chest pain, palpitations, shortness of breath, syncope, fatigue, and a cough. Now let's talk about heart failure. Congestive heart failure. So there's two types. We're going to have left-sided heart failure and right-sided heart failure. And these are going to look different. So our left-sided heart failure, if we think about the way that the blood pumps through the heart, right? It comes in to our heart on the left side. It goes to our left atrium. So it goes our atrium, right? It comes in on the right side. And it goes into our right atrium down to our right ventricle. Then it goes over through the lungs where it gets oxygenated. And then it comes back into our left atrium, down into our left ventricle, where it is then shot up and pumps through the entire body. So if we have left-sided heart failure, that means that this side of the heart is not pumping adequately. It's failing. So what's going to happen? The blood is going to back up, and it's going to back up into the lungs. So our signs and symptoms for left-sided heart failure are going to be pulmonary congestion, shortness of breath, tachypnea, crackles, cough, and hypertension because it's being backed up into the lungs. Our nursing, so for right-sided heart failure, it is similar where we have it, our right side of our heart is failing. So it's not pumping adequately. So the blood is coming in from the body. Blood comes in from the body. And now it's backing up. It's not pumping adequately out. So where is it backing up to? It's backing up into the body. So we're going to see signs and symptoms of edema, jugular vein distension, because if you think about it, this is the vein that is going into that right atrium. We're going to see abdominal distension, weight gain, and hypertension. So Our nursing interventions for both types of heart failure are going to be high Fowlers, supplemental oxygen, monitoring the output, fluid and sodium restriction, monitoring daily weights, monitor the number of pillows used to facilitate breathing while sleeping. All right, let's talk about valvular heart disease. So the first one is mitral stenosis. So this is a valvular tissue thickens and narrows the valve opening. It prevents blood from flowing from the left atrium to the left ventricle. Then we have mitral insufficiency. So this is a regurgitation. The valve is incompetent, preventing complete valve closure during systole. And then we have mitral valve prolapse, which the valve leaflets protrude into the left atrium during systole. So let's also talk about aortic stenosis versus aortic insufficiency. So with aortic stenosis, the valvular tissue thickens and narrows the valve opening, preventing blood flow from the left ventricle to the aorta. So this is the aorta. This is when it gets pumped into the body. It goes to the left ventricle into the aorta. So signs and symptoms, we're going to have dyspnea, angina, syncope on exertion, fatigue, orthopnea, paradoxical nocturnal dyspnea, and harsh systolic murmur. With aortic insufficiency, the valve is incompetent, preventing complete valve closure during diastole. Our symptoms are dyspnea, angina, tachypnea, fatigue, orthopnea, paroxysmal nocturnal dyspnea, a blowing decrescendo diastolic murmur. So again, these are key differences, right? We always want to remember the key differences. And valvular heart disease is repaired by a balloon valvuloplasty. So again, looking at these, there's a lot of similarities in how they present, right? But we want to look at the key differences. So to me, it's that murmur. So definitely memorize which type of murmur goes with which type of valvular heart disease. All valvular diseases are repaired by a balloon valvuloplasty, a mitroannuloplasty, a commissurotomy or a valvotomy, and valve replacement means that the patient has to be on anticoagulants for the rest of their life. Again, this is a key point, important to know. All right, let's talk about cardiac tamponade. So this is a fluid accumulation in the pericardium. Signs and symptoms are a pulseless paradoxis, a high CVP, jugular vein distension with clear lungs, muffled heart sounds, low cardiac output, and a narrow pulse pressure. Remember, we talked about how to find the pulse pressure. You take the systolic blood pressure and you minus the diastolic blood pressure. Our nursing interventions are going to be IV fluids and a pericardiocentesis, where they suck the fluid out. Let's discuss cardiac inflammation. So there's some different types. So we have pericarditis, myocarditis, and endocarditis. So pericarditis is an acute inflammation of the pericardium. Signs and symptoms are a sharp, pleuritic chest pain that's worse during inspiration. Again, this is a key point. You may see this in a question, and you should be able to identify that is a symptom of pericarditis. Coughing, relieved when leaning forward, a pericardial friction rub, fever, fatigue, and acute pericarditis, you'll see an ST elevation in all leads. Our nursing interventions include high Fowlers. This is our priority. Pain meds, NSAIDs, antibiotics, and monitor for tamponade. So a pulseless paradox, JVD, narrowed pulse pressure, tachycardia, and muffled heart sounds. Then we have myocarditis. This is an acute or chronic inflammation of the myocardium. So the thing that's nice, it kind of tells you where this is. The pericardium is for pericarditis. Myocardium inflammation is myocarditis. So our signs and symptoms include fever, a pericardial friction rub murmur. So again, there's a key. Signs and symptoms of chronic heart failure, or congestive heart failure, so fatigue, tachycardia, and chest pain. And our nursing interventions are assist to a seated position, oxygen if needed, periods of rest, avoid overexertion, pain meds, antidysrhythmics, and antibiotics. Then we have endocarditis. So this is an inflammation of the inner lining of the heart, or the endocardium. Kind of tells you in the name what area it is. So our signs and symptoms include fever, weight loss, fatigue, murmur, congestive heart failure, petechiae and splintering hemorrhages in the nail beds. So again, there's a key, and clubbing of the fingers. Signs and symptoms: rest, TED stockings, monitor for signs and symptoms of an emboli or thrombus, and antibiotics. Let's talk about cardiogenic shock. So this is the inability for the heart to pump blood adequately. Signs and symptoms include hypotension, tachycardia or a weak, thready pulse. Urine output is lower than 30 milliliters per hour. This is always a sign that something is wrong. That's never good. Cold, clammy skin, and disoriented. Then let's talk about deep vein thrombophlebitis. So our signs and symptoms include the patient presents as warm skin on the calf or groin pain with or without swelling. If a patient is saying that one calf is sore, so specifically one, it could be both, but typically it's one, and it's warm when you touch it and they're complaining of pain, that is a sign of a DVT. So risk factors include Virchow's triad, so decreased flow stasis, endothelial damage, and hypercoagulability state. Our nursing interventions include elevating the extremity above the level of the heart, avoid a pillow under the knees, do not massage the area because you can dislodge it. We want to apply anti-embolism stockings, measure the circumference of the thigh or calf, apply a warm, moist compress as needed. They're going to have antithrombolytics. We want to avoid prolonged sitting because the stasis of the blood is what can make it coagulate. Now let's talk about atrial fibrillation. So this increases the risk of a stroke due to increased risk of blood clots because the heart is, during atrial fibrillation, it's almost like fluttering. It's not like fully beating. So the blood is just pooling there and staying. It's not being pumped. And the stasis of blood is what can make blood clots. So our nursing intervention is the patient needs to be on anticoagulants. We monitor INR if on warfarin, monitor a change in heart rate, and monitor circulation. And just to clarify, this is the atrial part of the heart. So remember, we have our atrium up top and then our ventricle below. It's kind of like our right atrium, right ventricle, and then we have our left atrium and left ventricle in the heart. And then the blood gets pumped. It comes from the body into the right atrium, into the right ventricle. Then it gets pumped into the lungs, where it then goes into the left atrium, down to the left ventricle, and then out into the body. All right, so let's talk about percutaneous coronary interventions. So this is when a catheter is inserted into the femoral or radial vein and advanced into the pulmonary artery to obtain information about the structure and performance of the chambers, valves, and coronary circulation. The procedure will improve coronary artery patency and increase cardiac perfusion. However, there are some complications we need to look for, so thrombosis, a stent occlusion, a hematoma, and limb ischemia. Then lastly, mechanical valves. So when a patient has a mechanical valve, they'll need to be on anticoagulants for the rest of their life to avoid a thromboembolism. Let's talk about cardiac electrical activity. Different places in the heart that conduct electrical activity.
So the first one is the SA node. This is the main pacemaker. It initiates every heartbeat, generates impulses 60 to 100 beats per minute. That is the normal. This is known as the pacemaker of them. When this isn't working properly, patients typically need a pacemaker. Then we have the AV node. This is a place that receives impulses from the SA node. If the SA node does not work, then the AV node will take over and sustain a heart rate of 40 to 60 beats per minute. And then we have the bundle of His. This separates into the left and right bundle branches. It's located in the ventricles, and it can act as the pacemaker of the heart if the SA node and AV node fail, and the heart rate will be between 20 to 40 beats per minute. So when we talk about a pacemaker, this is a device that provides an electrical stimulation to maintain a heart rate when the patient's SA node fails to provide a rhythm. You'll see a ventricular spike on an EKG that indicates a pacing stimulus. So it will look like you'll have your EKG strip, and then you'll just see like a line, and then you'll see like the next heart rate, and then a line, and that is the pacemaker. You'll see the spike before the P wave for atrial pacing and a spike before the QRS complex for ventricular pacing. So this one would be atrial. And if you were going to see a ventricular, it would be over here right before the QRS. So our nursing interventions are going to be vital signs are monitored and cardiac monitoring is done continuously. We monitor for dizziness and weakness or fatigue, report swelling, redness, or drainage, teach patient how to monitor their pulse and signs of a low battery. We want to inform them of no cell phone use over the site, over where the pacemaker is. They don't want to put their cell phone on top of it. We want to teach them not to go for an MRI because we know the metal, right, can get pulled out during an MRI because it uses magnets. Microwaves are safe. It's just a rumor that you can't use microwaves with a pacemaker, so microwaves are fine. And we want to teach them to avoid heavy lifting after surgery. So let's talk about the vagal maneuver. So in order to have a patient do the vagal maneuver, you'll have them bear down. This is when you're like holding your breath, but then also trying to exhale. If you're ever on a plane and somebody says, try to pop your ears, it's that kind of maneuver. And this can be used to terminate a supraventricular tachydysrhythmia. So if a patient is in SVT, the first thing you can do is have them bear down, and sometimes that will pop them out of it. A cardioversion is a synchronized, and it has to be synchronized to the R wave if delivered on a T wave. It can lead to a lethal arrhythmia, so it has to be synchronized on the R wave. It is a counter shock to convert an undesired rhythm to a stable rhythm. And then we have defibrillation. This is an asynchronous counter shock, so this one does not have to be synchronized, that terminates pulseless ventricular tachycardia or ventricular fibrillation. So let's talk about cardiac rhythms. So first thing is determining the heart rate using a 6-second strip. So this method can be used to determine the heart rate for regular and irregular rhythms. When we are determining the atrial rate, we're counting the number of P waves in a 6-second strip, and then we're multiplying it by 10 because we know there's 60 seconds in a minute. If we want to find the ventricular rate, we count the number of R waves or QRS complexes in that 6-second strip. We multiply that by 10. It's also important to know that there are 30 boxes in a 6-second strip, and timing should begin on the P wave or QRS and end exactly after 30 blocks, which is a 6-second strip. Let's talk about cardiac rhythms. So the first rhythm we're going to talk about is sinus bradycardia. And we can see that this is a 6-second cardiac strip. When we have a 6-second cardiac strip, we can take the amount of beats in that strip and multiply it by 10, and we'll get the beats per minute. So in this one, we find our QRS, and we have 1, 2, 3. So 3 times 10
equals 30. So this is showing 30 beats per minute, which would be sinus bradycardia. Anything less than 60 is a sinus bradycardia. We can also see that because we have a normal rhythm. So we have our P, our Q, our S, and then our T wave. So that is all normal. So it's sinus bradycardia. So again, our rhythm, our P wave and QRS is regular. Our heart rate, P waves and QRS complex, both less than 60 beats per minute. We said we had 30. Our P wave is consistent and one before each QRS. That's true, right? PR interval is 0.12 to 20 seconds and consistent, and our QRS is less than 0.12 seconds and consistent, so true. So the pathophysiology, we have a slow heart rate, less than 60 beats per minute. This can arise from a normal pacemaker in the heart. It can be the SA node. It can just be slow resting heart rate, sometimes in athletes. Our P wave is normal and followed by a normal QRS and a T wave. So our assessment, we want to look at subjective and objective information. So objective, we're looking at, is there any syncope? Or subjective, we're looking at any syncope, dizziness, lightheadedness, chest pain, shortness of breath, exercise intolerance. These are things that the patient says they feel. Objective is what we can see. So decreased level of consciousness, cyanosis, peripheral edema, pulmonary vascular congestion, dyspnea, poor perfusion, and syncope. Our nursing diagnoses are going to include decreased cardiac output, risk for injury, risk for fluid volume overload. And our interventions, they may need atropine if symptomatic to raise up their heart rate. It would be given by an IV at 0.5 milligrams at 3 to 5 minutes apart for a total of 3 milligrams. Treatment is directed at the cause, which could include discontinuing meds, preventing vagal stimulation. And our treatment goals is for the client to remain syncope-free, to show a normal sinus rhythm, and have them remain free of injury. So now let's talk about sinus tachycardia. So same thing we just talked about, we're looking at a 6-second strip. We can see all of the different waves. So we can see our P, our Q, our S, and our T. So that is normal. But when we look at our 6-second strip, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. And if we take 13 times 10, because we want to figure out how many beats per minute, and we know it's a 6-second strip, and 6 times 10 is 60 seconds, which is 1 minute. So we take our 13 times 10 equals 130 beats per minute. So we can see our P wave QRS is regular, our heart rate is above 100 beats per minute. Our P wave is consistent, one before each QRS. Our PR interval is normal, our QRS is normal. So the pathophysiology, so we see the elevated heart rate of 100 beats per minute or more. Causes could include shock, fever, stress, exercise, which would be normal, anxiety, pain, or stimulants. So again, subjective is what the patient says they feel. So I feel a racing heart, anxiety, chest pain. Objective is what, so decreased blood pressure or an increased heart rate. Our nursing diagnoses could include anxiety, risk for injury, knowledge deficit. And our interventions are going to be things like a calcium channel blocker, carbamazepine, digoxin, or beta blockers to help slow down that heart rate. Our treatment goals is for the client to have less anxiety, have decreased or absent chest pain, to them demonstrate understanding of how to decrease their heart rate. So this has to match up with whatever our diagnosis was. All right, so now let's talk about atrial fibrillation. So if we look at this heart rate, we can see that, first of all, our QRS. And our QRS is our ventricle. That kind of shows us our ventricle. So our QRS is not regular, right? The distance from here to here is different from here to here. So that's the first thing. Then if we look for our P wave and our T wave, it's not here, right? We just have this like fibrillation, we can call it. So this is atrial fibrillation. So again, our ventricle rhythm, our QRS is irregular. Our heart rate, the atrial, has multiple rapid impulses from many areas of the atria, resulting in the characteristics of a fibrillatory line. So that's talking about this. Ventricular usually responds at a heart rate of 120 to 200 beats per minute. So we can see the ventricle is beating. So P wave, no clear P wave, no clear PR interval. So our pathophysiology, the atria of the heart, so the top of the heart, we have our right atrium, our right ventricle, our left atrium, our left ventricle. So this top part, our atrium, is quivering and the blood is not being pumped out of the atria. So we know that when blood is stagnant in the heart like that, there is an increased risk of blood clots because the blood is pooling. The causes are usually hypertension, valvular, ischemic, and other types of structural diseases. So again, subjective, the patient may say they feel their heart racing. You're going to see decreased blood pressure, increased pulse rate. We have some nursing diagnoses there, but our interventions are going to be Coumadin if the client has been in a rhythm greater than 48 hours. If it's unstable, they may need a cardioversion. It depends on the cause or durations. Clients can convert to a normal rhythm spontaneously within 24 hours. So we want to check if they're symptomatic. If not, there may not be much we can do. So we may have to do those cardioversions and the medications, things like that. All right, let's talk about atrial flutter. So again, we're seeing something similar where we have our QRS here. So we're seeing those beats. However, when we look at our P and our T, it's definitely irregular, right? You can't see those waves. And the main thing that you'll see in questions is they call this a sawtooth pattern. If you see that, that's atrial flutter. So our rhythm is irregular. Again, the distance between here and here is different than the distance from here to here. Heart rate greater than 100 beats per minute, no P wave, no PR interval, and a narrow QRS. So you can see this is narrow. So pathophysiology, tachyarrhythmia is most often contained within the right atrium. It's defined on an EKG by a sawtooth pattern of flutter waves, has negative polarity in leads 2, 3, and VF. The assessment, so again, patient may say they feel chest pain or a racing heart rate. You may see blood pressure decrease, loss of consciousness, mental status change, a regular fast heart rate. Our interventions for this are a cardioversion, and treatment goals, big things are restoring sinus rhythm, preventing thromboembolic complications, minimizing adverse effects of the therapy. All right, so let's talk about preventricular contraction. So when we talk about, this is also called a PVC, and you can see them here and here. So the rhythm is irregular because we can see it kind of changes, right? Heart rate varies. You'll see a P wave. There will be a wide PR interval. So again, it's going to be here, okay, and here. And our QRS is going to be narrow, but very big. So this is our PR. Okay, pathophysiology. So extra abnormal heartbeats that begin in one of the ventricles. These extra beats disrupt your regular heart rhythm, causing the patient to feel a flip-flop or skipped beat in chest. It can be caused by hypoxia, low potassium, caffeine, and stress. Patients will say they feel their heart skipping a beat, anxiety, stressed. Some people may say, oh, I drank caffeine. You'll see decreased oxygen. You might see their potassium low. You might see a low blood pressure, heart rate less than 60 beats, or decreased level of consciousness. And that the intervention is, again, a cardioversion. All right, so ventricular tachycardia. So you can see there's no QRS here, right? It's just this tachycardic rhythm that is irregular. We don't have a P wave. We have wide QRSs. Like, these are all really wide, and we can't identify a PR interval. So pathophysiology, so it's a type of regular and fast heart rate that arises from improper electrical activity in the ventricles of the heart. Ventricular tachycardia may turn into VFib and cardiac arrest. If it's sustained, the heart rate can be greater than 120 beats per minute, and it can last greater than 30. Non-sustained, a heart rate is greater than 120 beats per minute, but lasts less than 30 seconds. Assessment, subject might say, I feel almost dead. The client might not be able to talk. They might have shortness of breath, chest pain, dizziness, lightheadedness. You're going to see palpitations, cardiac arrest, heart rate of greater than 100 beats per minute. And our intervention is we can have them try to do a vasovagal maneuver, but if they have a pulse, and amiodarone. If they have no pulse, then they need immediate defibrillation. So let's talk about ventricular fibrillation. So again, we talked about we have the atrium at the top, the ventricle at the bottom. So this is when now that ventricle is just fibrillating. It's not pumping, right? If we look at this rhythm, we really can't determine anything. There's no regularity, there's no heart rate, there's no P wave, there's no PR interval. We can't determine the QRS. So the pathophysiology is coordinated contractions of the ventriculomyocardium is replaced by a high-frequency disorganized excitation, resulting in the failure of the heart to pump the blood. Patient may say they feel short of breath, chest pain, dizziness, lightheadedness, nausea. You might see low blood pressure, fainting, cardiac arrest, and a heart rate of less than or greater than 100 beats per minute, and palpitations. Our interventions include defibrillation and CPR. So asystole, we have nothing. So pathophysiology, there's no electrical activity on the EKG monitor. Client's probably unconscious. You're not going to see a pulse. So our interventions, this is our high quality CPR. They might need epinephrine. The recommended dose is 1 milligram IV push every 3 to 5 minutes. Vasopressin, 40 units IV is acceptable in place of first or second dose of epinephrine. And defibrillation will not work for asystole. That is important to know. Then we have paroxysmal supraventricular tachycardia. So if we look at this, we have an irregular rhythm. Our heart rate is greater than 100 beats per minute. There's no T wave, no PR interval, and a wide QRS. Pathophysiology is the rapid heartbeat that develops when normal electrical impulses of the heart are disrupted, and this can convert to ventricle tachycardia. Patient may say they feel like they're going to faint, dizzy, or chest pain. We're going to see a rapid pulse and diaphoresis. Our interventions are adenosine, rapid push 6 milligrams, followed by 20 milliliters of normal saline, and the heart rate will stop. So first degree heart block. We can remember this if R is far from P. So we have our P wave here, Q, R, ST. So we're looking at this distance. So rhythm is regular, heart rate is less than 60, normal P wave, PR interval greater than 0.2, and a wide QRS. So pathophysiology, the wiring of the heart is slowing to send electrical activities, but all of the signals are able to pass successfully. There's no electrical block, but rather a slowing or delay of the signal, and this usually does not cause a problem. Causes include enhanced vagal tone, acute myocardial infarction, myocarditis, electrical disturbances. Subjective, the patient may rarely show symptoms. You may see a slow pulse. Interventions, there's usually no medical intervention required. When we talk about second degree heart block, this is also called Morbitz type 1, Wenkebeck. We can remember this as further drop. So if we look at our P and our R distance, we can see that it gets bigger and bigger and bigger, and it will drop. So rhythm, increasingly prolonged, heart rate's normal, P wave normal, PR increases with each beat until the QRS drops. So we can see we're missing our QRS here. So the QRS drops every third or fourth block. Pathophysiology, so a progressive prolongation of the PR interval until eventually an atrial impulse is completely blocked. And when the atrial impulse is completely blocked, there will be a P wave without a QR complex. Patient will say, rarely do they show symptoms, but they might be dizzy. You'll see a slow pulse. And interventions are atropine followed by a pacemaker. When we talk about second-degree heart block or Morbitz type 2, we can remember this: if some Ps don't get through, you'll have a Morbitz type 2. So we're going to see a QRS dropped in an unpredictable pattern. So we can see a QRS here dropped. Our PR is constant, same duration. P wave is normal. Heart rate's less than 60 beats per minute. Our rhythm for our atrium is regular, but our ventricular is irregular because, again, that's the QRS. Pathophysiology, usually the disease of distal conduction system. There's an intermittent non-conductive P wave without progressive prolongation of the PR interval and can progress to complete heart block. Patient might complain of fainting, dizziness, lightheadedness, chest pain, shortness of breath. You might see a slow pulse. And our interventions will be a pacemaker. So third-degree heart block, complete heart block. So for this, our QRS will be present but not equal to the amount of P waves. And we can remember this as P and Q don't agree. So we can see our P wave here, and they're all kind of different distances. We'll see our PR interval is delayed. Our P wave is inconsistent, sometimes more than the QRS. So again, we can actually see 2 here. Rhythm is regular, and our heart rate is less than 60 beats per minute. So pathophysiology, there's no communication between the atrial and the ventricles, and there's diminished cardiac output. Patient may say they feel like they're going to faint, dizzy, lightheaded, chest pain, shortness of breath. You're going to see a low pulse. And our interventions include IV titrated dopamine drip followed by a pacemaker. And now a paced rhythm. So our regularity is irregular, heart rate varies, P wave is inconsistent more than QRS, PR release is delayed, QRS is present but not equal to the amount of P waves. So this is why we place a pacemaker. So the pathophysiology, we're going to see ventricle spikes on short duration, usually every 2 milliseconds. So you can see these right here. So those are our pacemaker in the EKG. And our interventions include clinical monitoring, telling them not to do an MRI because of the magnet, and there are certain ways we can turn it on and off. So first, let's talk about sinus tachycardia. So the rhythm is regular, the rate is going to be greater than 100 beats per minute. Our P waves, our sinus, they're normal. Our interval is 0.12 to 0.20, and QRS is around 10 seconds. For sinus tachycardia, you have a regular rhythm, right? It has that same kind of regular rhythm, but there's just a lot of them because it's beating fast. When it comes to sinus bradycardia, it is a slow rhythm. So we're looking at beats of 40 to 60 beats per minute. And there's no treatment unless symptomatic. So if they have low blood pressure and loss of consciousness. When we talk about supraventricular tachycardia, we're seeing again a very fast heart rate. The rhythm is normal. It's just beating really fast. But the P and T waves have now formed into one wave. The PR complex interval is not measurable, and the QRS is around 10 seconds. So this is an unstable rhythm. You'll see they may need a cardioversion. They may have a low blood pressure, loss of consciousness, or chest pain. And that's if they're unstable. So there's 2 types. We have unstable and then stable. You could see sedation. You can have them try that vagal maneuver we talked about earlier where they bear down, and they may need a bolus of adenosine. Then we have atrial flutter. So again, the rate is 250 to 400 beats per minute. The ventricular is beating normal, but it's less than the atrial. And again, that atrial is in a flutter. It's just fluttering. For the P wave, you're going to see a sawtooth pattern. This is a key. If you see in a question, it's saying you see a patient's rhythm that's in a sawtooth pattern, that is going to be atrial flutter. And It's important to know that to control the ventricular rate, they'll use dilazepam. A flutter less than 48 hours long, they'll need a cardioversion, and if it's greater than 48 hours long, they will anticoagulate before attempting the cardioversion. Then we have atrial fibrillation. So a key for this is the P wave is fibrillatory, and we're seeing a heart rhythm of 350 to 600 beats per minute in the atrial, and ventricular is going to be less than that. But again, that atrial is just fibrillating. So we want to control the rate first. So again, we're using that dilazepam, AFib less than 48 hours long, cardioversion or anticoagulation in AFib greater than 48 hours long. Again, anticoagulate before attempting cardioversion. And unstable AFib, we will cardiovert ASTAT. All right, so first degree heart block. So this is a regular rhythm. It's just going to depend on the underlying rhythm, how fast it's beating. If there are no symptoms, it requires no treatment. Then we have second degree heart block, type 1, and the atrial is beating regularly, but the ventricle is not. The atrial is going to beat at a rate that matches whatever the underlying rhythm is, but the ventricular will be less than that. You're going to see the PR lengthening progressively until QRS drops. And this is also called Weinkeback. And then second degree type 2 block, this is, again, atrial is beating at the underlying rhythm, ventricle less than atrial rate. Our sinus will be 2 to 3 P waves before each QRS. Once again, these are the key things to know. Usually ventricular rate is slow. We can see strokes, atom syncope caused by suddenly slowing of the heartbeat, and treatment is usually a pacemaker. All right, so third degree heart block, again, atrial regular, ventricular regular. Atrial is the same as the underlying rhythm. Ventricular is going to be 40 to 60 beats per minute. Sinus P wave has no relationship with the QRS. P waves may be hidden. Atrial and ventricular beat independently of each other. Symptoms include hypotension, dyspnea, heart failure, chest pain, strokes, atom syncope, and treatment again is a pacemaker. Then we have ventricular tachycardia. So we're going to see 140 to 250 beats per minute. We're going to have an absent P wave, and the QRS is going to be wide. So if it's stable, we're going to do amiodarone bolus over 10 minutes. Once rhythm converts, an amiodarone infusion. If this is unsuccessful, they'll need a cardioversion. If it's unstable, we'll sedate the patient, cardiovert, and maintain an infusion of amiodarone. Then we have premature ventricular contractions. These patients are going to be tachycardic. There may be no P wave before a premature QRS. It will be wide. For a client experiencing PVCs, we want to notify the healthcare provider if they complain of chest pain or if the PVCs increase in frequency, are multifocal, occur on a T wave, or occur in runs of ventricular tachycardia. Ventricular fibrillation, have no rhythm, no rate, absent this. So if it's witnessed, them going down, we defibrillate. If it's unwitnessed, we do CPR for 2 minutes before initiating shock and BLS. And then asystole, again, no rate, no rhythm, P wave is absent, not measurable QRS. We have an absent QRS. So if we witness, again, defibrillate, unwitnessed CPR for 2 minutes before initiating shock and BLS. Let's review the renal system. So the first thing we're going to cover is just a small review of anatomy and physiology. So the role of the kidneys. So the kidney regulates water and ionic compounds of the body, excretes waste, excretes foreign chemicals, produces glucose during prolonged fasting, and secretes hormones. The three basic renal processes of glomerular filtration, tubular reabsorption, and tubular secretion. In addition, the kidneys synthesize and catabolize certain substances the excretion of a substance is equal to the amount filtered plus the amount excreted minus the amount reabsorbed. So let's talk about normal renal function values. So the first one we have is blood urea nitrogen, or BUN, and this is anywhere from 10 to 20. The BUN level indicates the extent of renal clearance of urea, nitrogenous waste products. An elevation does not always mean the renal disease is present. Then we have serum creatinine level. In a male, this is going to be from 0.6 to 1.2, and in a female, it's 0.5 to 1.1. Creatinine levels reflect the glomeal filtration rate and increases only when 50% of renal function is lost. Then we have a BUN creatinine ratio, and this is going to be anywhere between 6 and 25. And then we have creatinine clearance test. The normal is 125 milliliters per minute. The creatinine clearance test provides the best estimate of glomeal filtration rate. It evaluates how well the kidneys remove creatinine from the blood and is an estimate of the glomeal filtration rate. The glomeal filtration rate decreases with age, about 10% per decade, and by age 65, it is 65 milliliters per minute is the average. All right, so let's talk about acute kidney injury. So this happens quickly and is reversible. So let's look at the different phases in laboratory findings. So first, we're looking at the onset. It begins with a precipitating event. That's because it's acute. And anything acute, it's not chronic. It's not long-term. It's not untreatable. So acute is something happens that causes a problem that is reversible and fixable. And if it's not reversible or fixable, then it turns into a chronic problem. So it begins with some precipitating event, and it has some phases. So the first phase is called the oliguric phase. And during this phase, we're going to see an elevated BUN and serum creatinine levels. We're going to see decreased urine-specific gravity if it's caused by a prerenal cause, or the urine-specific gravity will be normal if it's an intrarenal cause. Then we'll see a decreased glomeal filtration rate and creatinine clearance. We'll see hyperkalemia, normal or reduced sodium, hypervolemia, hypocalcemia, hyperphosphatemia. Then we move on to the diuretic phase. So this is, we're going to start to see a gradual decline in the BUN and serum creatinine clearance will still be elevated. So both of these will still be elevated, but it's going to start to go down. Then we're going to see a continued low creatinine clearance with improved glomeal filtration rate. We'll see hypokalemia and hyponatremia, and we'll see hypovolemia. Then we have the recovery phase. So now we're going to start to see an increase in the glomeal filtration rate. So it's going up again. We'll start to see a stabilization or continued decline in the BUN and creatinine levels toward normal. And we'll start to have a complete recovery, but it could take as long as 1 to 2 years. So what are our nursing interventions? As we can see, so to be honest, you probably do not need to remember all of the hypocalcemia, hyperphosphatemia in the oliguric phase, and then in the diuretic phase, hypokalemia, hyponatremia. Like, that's a lot to remember, but an important thing, because that would be a very specific question to get on NCLEX. If you're getting a question like that, you're probably doing really well, because that's a very difficult question to memorize all that material. But you'll probably get a question related to electrolytes and nursing intervention. So we should know that with acute kidney injury, you're having electrolyte imbalances. So that's a big thing. So monitoring electrolyte levels is important. And specifically, we remember that potassium is the most risky when that one is out of balance. So if it's asking you, like, what is your priority electrolyte to monitor with an acute kidney injury or something like that, and potassium is one of the answers, go with that because that's where you're going to have the cardiac abnormalities and things like that. But monitoring electrolytes, important with kidney injuries. Monitor blood pressure and vital signs. Monitor intake and output with daily weights. All of these are really important. The interventions are really what you should memorize. Want to remember renal disease, so that's a low protein, high carb diet. They may need dialysis, and we may need to monitor for acidosis. The treatment for acidosis is sodium bicarbonate. Chronic kidney disease. So this now is a slow, progressive, and irreversible loss of kidney function. So a normal glomerular filtration rate is going to be 90. Mild chronic kidney disease will be anywhere between 60 and 89. Normal, mild. Okay, and then moderate chronic kidney disease, glomerular filtration rate is 30 to 59. Severe is going to be 15 to 29. And end stage is a glomerular filtration rate less than 15. This is going to require dialysis, which is the process of filtering the patient's blood and removing wastes. Patients are at risk for fluid overload and hyperkalemia. So these are things we should be monitoring for. So now when we talk about our nursing interventions during dialysis, we're monitoring for hypovolemia and shock. We're monitoring for bleeding. We're going to hold antitensive and meds that could be removed during dialysis, such as water-soluble vitamins, antibiotics, or digoxin. We're going to monitor for arterial steal syndrome in patients with internal AV fistulas, which is too much blood is sent to the vein that the arterial perfusion to the hand is compromised. And we'll palpate for a thrill or auscultate a bruit to ensure the fistula is pending. This is when you use your stethoscope and you put it on the fistula, whether it's wherever it is on the arm, etc., and you're listening for a whooshing sound, and that's showing that the blood is passing through there and it's working properly. Let's talk about an air embolism in a client with dialysis. So how do we treat this? We stop the hemodialysis. We turn the client on the left side with the head down, which is Trendelenburg position. Notify the healthcare provider and rapid response team. Administer oxygen, assess vital signs and pulse, and document the event, actions taken, and client's response. So you may get a question on NCLEX, like the way NCLEX will ask questions, like what do you do first? What is the priority? It is never contact the healthcare provider. There's always something that you should do first, and we're thinking patient safety. So if they're like, there's an air embolism, what do you do? So first, stop the hemodialysis, turn the patient on the left side with the head down in Trendelenburg position. Then you notify the healthcare provider. Okay, now let's talk about kidney transplant. So a transplant can come from a living or deceased donor. They must have the same blood type and antibodies. The patient will be on an immunosuppressive medication for life. So our nursing interventions are going to be to monitor urine output, which starts immediately after the transplant, daily weights, and semi-Fowler's position. We want to remember to instruct the client following a kidney transplant to avoid prolonged periods of sitting, monitor intake and output of urine, recognize the signs and symptoms of infection and rejection, use medication as prescribed, and maintain immunosuppressive therapy for life, avoid contact sports, and avoid exposure to people who have infections. So what are the signs of rejection? So a temperature higher than 100 degrees, pain or tenderness over the grafted kidney, a 2 to 3 pound weight gain in 24 hours, edema, hypertension, malaise, elevated blood urea nitrogen and serum creatinine levels, decreased creatinine clearance, and elevated white blood cell count. All right, let's talk about a UTI. So UTIs may experience cloudy, malodorous, or bloody urine. There are two types of UTIs. So we have a lower UTI. This is in the urethra, cystitis due to ascending pathogens such as E. coli. Signs and symptoms are frequency, urgency, and burning. Then we have an upper UTI. These are things like polynephritis due to urine reflux from the bladder into the ureters or obstruction causing inflammation. These signs and symptoms are calculi, structure, and an enlarged prostate. Nursing interventions, we want to give them antibiotics and monitor for confusion in the elderly. This is a big thing. When elderly people get UTIs, they can really be delirious and things. And then continuous bladder irrigation removes clotted blood from the bladder post-TURP, which is a 3-way catheter that is used. Nursing interventions report pain and spasms, which indicate obstruction. Report if output is less than the input, which indicates a clot or kink. And titrate irrigation rate so that urine is light pink. Let's review the reproductive system. So first, let's talk about irregularities associated with menses. So we have amenorrhea, which is characterized by a lack of or uncharacteristic pause of menses. Then we have dysmenorrhea. This is painful menses. Hypomenorrhea, which is a limited period or period of short duration. Hypermenorrhea, this is extensive menses. Olgeomenorrhea, this is irregular menses. Polymenorrhea, this is abnormally frequent menses. And anovulation cycle is characterized by a menstrual cycle in which a woman does not ovulate. Okay, now let's talk about endometriosis. So endometriosis is the occurrence of endometrial tissue in an area other than the uterine cavity. The signs and symptoms are painful intercourse, dysmenorrhea, which is painful menses, dyschezia, difficulty producing stool, pelvic pain, premenstrual spotting, and spontaneous abortion. Then we have pelvic inflammatory disease. This is an acute or chronic inflammation of the endometrium, uterine tubes, and pelvic peritoneum. So chronic or acute inflammation caused by either gonorrhea, chlamydia, and is usually the end product of an untreated STD. So signs and symptoms, pain and vaginal bleeding, nausea, vomiting, purulent drainage, fever, and elevated white blood count. Okay, let's talk about sexually transmitted diseases. So first we have chlamydia. This is a sexually transmitted bacterial infection. In males, we're going to see things like urethritis, epididymitis, proctitis, and Reader syndrome. In females, we're going to see cervicitis and urethritis, inflammation or infected Barthonian glands, and pelvic inflammatory disease. Then we have gonorrhea. This is a contagious inflammation of the genital mucosa and may affect the genital tract, both upper and lower, the urethra, endocervix, peritoneum, the heart, and any joints in the body, and any other area via the bloodstream. We're going to see polyuria, painful urination, and discharge. Then we have syphilis. This can invade any system within the body and cause damage to bone, tissues, and nerve. We'll see fever, eruptions of mucosal patches on the skin, lymphadenopathy, a painless canker papule that manifests 0.3 up to 2 centimeters non-tender ulcer that has a formed border with a yellowish base, flu-like symptoms, and a rash. Then we have human papillomavirus, or HPV. Things we will see include venereal warts, so characterized by a growth of warts on the anal or genital area, may appear as a single or in clusters, and are fleshy, skin-colored, and may be soft to touch. Signs and symptoms are soft, sessile, having a broad base of attachment. Tumors may be smooth or roughed, pruritus, itching, and bleeding at the site. And our nursing interventions are we should educate that females should have a pap smear at 21 years old. And then we have pubic lice. And our interventions for this are lice shampoo, remove nits with a fine tip comb, wash belongings separately from others, and sexual partners need to be treated as well. So let's talk about the endocrine system. So a quick anatomy overview is we have endocrine glands throughout our body, which are our adrenals, hypothalamus, ovaries, pancreas, parathyroid, pituitary, testes, and thyroid. Then we have something called metabolic syndrome. So this is 3 or more of the following factors are present, and it increases a patient's risk for stroke, diabetes, and cardiovascular disease. So abdomen obesity, high triglyceride levels, low HDL, and a fasting blood sugar greater than 110. So let's talk about endocrine disorders. So we have our hypo and hyper. So when we talk about hypo, pituitary growth hormone and gonadinoid hormone, we're talking about hypopituitarianism. And then when we talk about an increase of the growth hormone, it's hyperpituitarism. So let's compare the two. So hypo is a hyposecretion or one of more of the pituitary hormones caused by tumors, trauma, encephalitis, autoimmunity, or stroke. So we're talking about pituitary hormones, right? Because we have all these different endocrine glands. With hyperpituitarism, we have a hypersecretion of the growth hormones. Our signs and symptoms for hypopituitarism, so when it's low, is mild to moderate obesity, reduced cardiac output, infertility, sexual dysfunction, fatigue, low blood pressure, tumors of the pituitary that may cause headaches or visual deficits. And our nursing interventions are we may need hormone replacement, and we need to educate them on signs of hyperpituitarism because if they have too much medication, it can cause that. So when we talk about hyperpituitarism, our signs and symptoms include large hands and feet, thickening and protrusion of the jaw, arthritic changes of the joints, visual disturbances, diaphoresis, oily, rough skin, organomegaly, hypertension, atherosclerosis, dysphagia, deepening of the voice, thickening of the tongue, narrowing of the airway, hyperglycemia, colon polyps, and colon cancer risk. So I think Tony Robbins has this. I don't know if you guys know who Tony Robbins is, but if you look him up, I think he has this, and you can see he's a very large man, large hands and feet. He's got very big kind of jawline, and he has some really good talks. So nursing interventions, we're going to provide pharmacological interventions to suppress or block the action of the gonadotropic hormones. We're going to prepare the client for pituitary gland radiation, stereotactic radiosurgery, or hypophycectomy if planned. We're going to offer them pain relief and emotional support. All right, so now when we talk about the hormone ADH, posterior pituitary is the endocrine gland involved. What we're going to see is diabetes insipidus if it's low. So again, this is, let's just add hypo and hyper so we can see it. All right, so if it's low, we have diabetes insipidus. This is caused by stroke, trauma, and surgery. This is when the kidneys fail to reabsorb water. Signs and symptoms include a large amount of dilate urine, polydyspnea, dehydration, low urine-specific gravity, fatigue, headache, tachycardia, postural hypertension. In our nursing interventions, we're going to monitor vital signs, monitor electrolytes, maintain fluid intake, may need an IV, monitor intake and output and weight. Now when we talk about syndrome of inappropriate antidiuretic hormone secretion, again, this is the hyper ADH, causes or trauma, stroke, malignancies, medication, and stress. Signs and symptoms are that it leads to a water intoxication and hyponatremia. Nursing interventions monitor for fluid overload, change in level of conscious, weight gain, hypertension, tachycardia. We want to monitor their neuro status, so looking for signs of that increased intracranial pressure. Monitor intake and output, monitor weight, serum osmolarity, urine-specific gravity. We want to restrict fluids, administer diuretics, and have them on seizure precautions. These patients will need lifelong glucocorticoid replacement. All right, then we have Addison's disease and Cushing's disease. So this has to do with cortisol, and this is from the adrenal gland. So we have Cushing's is going to be hyper, and Addison's is going to be hypo. So for Addison's, signs and symptoms are lethargy, fatigue, muscle weakness, gastrointestinal disturbances, weight loss, menstrual changes in females, impotence in males, hypoglycemia, hyponatremia, hyperkalemia, hypercalcemia, hypotension, hyperpigmentation of the skin. Then we have something called Addisonian crisis. Different color. There we go. And this is an acute adrenal insufficiency caused by stress, infection, trauma, surgery, or withdrawal from corticosteroids. Signs and symptoms are severe headache, weakness, hyponatremia, hyperkalemia, hypoglycemia. You get severe abdominal, leg, and lower back pain, irritability and confusion, severe hypotension or shock. And our nursing interventions are to administer fluids and glucocorticoids IV. Post-crisis, we're giving PO glucocorticoid, monitor vital signs, neurostatus, intake and output, maintain bed rest in a quiet environment. Patients with Addison will need lifelong glucocorticoids. During times of stress, glucocorticoids will need to be increased. So just an important fact. Then let's talk about Cushing's syndrome. So again, this is when we have a high level of cortisol. So this is a metabolic disorder resulting from chronic and excessive production of cortisol from the adrenal cortex or from the administration of glucocorticoids in a large dose for several weeks or longer, or from ACTH secreting hormones. So Cushing's disease, this is a metabolic disorder with increased secretions of cortisol caused by increased amounts of ACTH secreted by the pituitary gland. Signs and symptoms for both include muscle weakness and wasting. You'll see the moon face and buffalo hump, truncal obesity, hirsutism, which is masculine features in a female. They might get hair on their face, hyperglycemia, hypernatremia, hypertension, fragile skin, bruises easily, and striae on the abdomen, which is stretch marks. Nursing interventions, we're going to monitor vital signs and monitor intake and output. All right, so then let's talk about the thyroid. So again, we have, so for hypothyroidism, our T4 is low and TSH is elevated. We have decreases in the body's metabolism. Signs and symptoms are going to be lethargy, fatigue, weakness, muscle aches, cold intolerance, weight gain, dry skin and hair, constipation, edema around the eyes and face, bradycardia and cardiac enlargement, and sometimes a goiter. A lot of times you can think that this is like everything is slowing down. Let's do hypothyroid. Okay. So our nursing interventions are going to include monitoring vital signs and heart rhythm, administer thyroid replacement, usually levothyroxine, monitor for overdose on thyroid meds. So we're looking for signs of hyperthyroidism, instruct the client on a low-calorie, low-saturated fat diet. To go along with hypothyroidism, we also have something called myasthenia coma. So we can see up here that one of these signs and symptoms was edema around the eyes and face, which is myasthenia. A myasthenia coma is due to persistently low thyroid production. We're going to see hypotension, bradycardia, hypothermia, hyponatremia, hypoglycemia, generalized edema, respiratory failure, and then coma. This is not good. We don't want this to happen. So our nursing interventions, if this happens, is to maintain a patent airway because our airway breathing circulation. Aspiration precautions, IV fluid. We're going to give them that levothyroxine levothyroxine intravenously along with glucose. We're going to assess clients for temperature hourly, keep client warm, monitor for changes in mental status, and monitor for electrolytes and glucose levels. Now when we talk about hyperthyroid, let's do hyperthyroid. So for hyperthyroid, our T3 and T4 are high, but our TSH is low. It increases the body's metabolism, and this can be caused by Graves' disease. So signs and symptoms are irritability, nervousness and fine tremors, heat intolerance, weight loss, smooth skin, palpitations and cardiac dysrhythmias, diarrhea, exophthalmos, this is bulging eyes, hypertension, and goiter. So the way we can think about this is everything is speeding up. Our nursing interventions are going to include providing rest, administering sedatives, providing a cool, quiet environment, provide a high-calorie diet, avoid stimulants, administer anti-thyroid medication or iodine preparations, administer propranolol for tachycardia. If the patient has exophthalmos, so the bulging of the eyes, we're going to elevate the head of the bed, give them a low-salt diet, artificial tears, use dark glasses, or tape eyes closed at night because sometimes they're popping so much the eyelids won't close. Then we have something along with hyperthyroid called thyroid storm, and this is uncontrollable hyperthyroidism. We're seeing things like fever, tachycardia, systolic hypertension, agitation, tremors, confusions, delirium, seizures, and coma. And our nursing interventions include maintaining a patent airway, administer anti-thyroid medications, propranolol and glucocorticoids, monitor vital signs, and cardiac dysrhythmias. Now we're going to look at the parathyroid. So we have hypoparathyroid and hyperparathyroid. So for hypoparathyroid, we're seeing hypocalcemia and hyperphosphatemia, tingling of the and muscle cramps, a positive Terso's and Chauvet-Tex sign. We're going to see tetany, hypotension, anxiety, irritability, and depression. So we can see for a lot of these, there's some overlap with all the electrolytes and things like that, but a positive Trousseau's and Chauvet-Tex sign with hypoparathyroid, that's important to know because it's very specific. So nursing interventions, we're going to monitor vital signs, tetany and hypocalcemia, initiate seizure precautions, place a trach kit, O2 and suction at the bedside. They may need calcium gluconate IV. They may need vitamin D for enhanced absorption of calcium, and instruct the client on a high calcium, low phosphorus diet. When we talk about hyperparathyroid, we're going to see hypercalcemia and hypophosphatemia, fatigue, muscle weakness, bone deformity, skeletal pain, anorexia, nausea, vomiting, weight loss, constipation, hypertension, cardiac dysrhythmias, and renal stones. And our nursing interventions are monitoring vital signs, specifically blood pressure, monitor for dysrhythmias, INOs, and renal stones, administer furosemide to lower the calcium levels, administer calcitonin and phosphates and biophosphates. Okay, so let's talk about insulin and pancreatic disorders. So we have two types. We have type 1 diabetes and type 2 diabetes. Let's talk about insulin and pancreatic disorders. So the first is going to be type 1 diabetes. So this is an absolute insulin deficiency. They do not have any. If insulin is not given, fats are metabolized for energy, which leads to ketone production, which leads to acidosis. So signs and symptoms are polyuria, polydipsia, polyphagia, and weight loss. These are key to remember because this is what differentiates from type 2, because you're also going to have all of the same signs and symptoms that are in type 2, in addition to polyuria, polydipsia, polyphagia, and weight loss. Nursing interventions are to instruct the client to monitor their blood glucose levels before, during, and after exercise. and to provide insulin. Then we might see something called diabetic ketoacidosis. This is a life-threatening complication of type 1 diabetes. It is a sudden onset due to inadequate insulin doses, infections, or other stressors. In ketosis, there is Kussmaul's breath or Kussmaul's respirations, which is a fruity breath. This is a key sign. So just remember that. That goes along with DKA. We'll also see that polyuria, polydipsia, polyphagia, dry skin, sunken eyes, and coma. Diagnostically, what we're looking for is going to be urine ketones that are positive. Our serum pH is going to be less than 7.35, and serum glucose is going to be greater than 300, which is also a key, right? We're looking at those blood sugar levels. So our nursing interventions are to give IV normal saline first. So if you get a question, remember priority is IV normal saline first. We're going to do cardiac monitoring. We're going to monitor and correct electrolyte imbalances, short duration insulin through an IV, monitor vital signs, intakes and output, and monitor the client for signs of increased intracranial pressure. Then we're going to talk about type 2 diabetes. So this is a lack or resistance to insulin. There is enough insulin to metabolize fats and protein, but not carbs. We're going to see hyperglycemia, blurred vision, weakness, slow wound healing, and inadequate circulation to the feet. Our nursing interventions are to instruct the client with diabetes to monitor their blood glucose before, during, and after exercise, and provide insulin or oral medications. Then we're going to see something called hyperglycemia, hyperosmolar non-chaotic syndrome, or HNS. This is extreme hyperglycemia that occurs without ketone or acidosis, which is the major difference in DKA. It's usually seen in patients with type 2 diabetes. That's because we know that they have enough insulin to metabolize fat, so you're not going to see those ketones. Signs and symptoms: gradual onset due to infection, stressors, or poor fluid intake. Neurological symptoms such as lethargy, coma. Might see dehydration with increased thirst, electrolyte loss, and also the same symptoms as DKA. So we want to remember these are the differences, right? We always want to remember the differences. We don't want to have to memorize a bunch of information twice. So nursing interventions are similar to DKA interventions. Correct the IV normal saline first, correct electrolyte imbalances. Insulin replacement plays a less critical role than in DKA, and rehydration alone may fix this. All right, so let's discuss blood sugars. So we have hypoglycemia, which is a low blood sugar, and hyperglycemia, which is a high blood sugar. So for hypoglycemia, we're going to see things like cold, clammy, pale, irritable, weak, diaphoretic. For a moderate hypoglycemia, we may see mental status changes, confusion, irritability, headache, slurred speech. And for severe hypoglycemia, they'll be disoriented or loss of conscious and also seizures. Our nursing interventions include checking their blood sugar. If it's less than 70, we're going to administer 15 grams of simple carbs or half a cup of juice. Then we recheck the blood sugar in 15 minutes. If it's still less than 70, we want to give another 15 grams of simple carbs or half a cup of juice. Then we will recheck again in 15 minutes. If it's still less than 70, we want to administer 25 to 50 mLs of 50% dextrose IV, or we can treat with 1 milligram of glucagon sub-Q or intramuscularly. After the blood glucose has recovered, we can have the patient eat complex carbs and a protein snack. And if the patient has an altered mental status, we're going to start with the injectable glucagon. Then for hyperglycemia, we're going to see things like the patient's going to be hot and dry, have polyphagia, polyuria, polydipsia, blurred vision, and that fruity breath. And again, that diabetic ketoacidosis and hyperglycemic hyperosmolar non-chaotic syndrome. And we can see details of that in our previous section we went over. Now we're going to talk about types of insulin. So first we have rapid acting insulin. So this is our Lispro, Aspart, and Glulisine. These have an onset of less than 15 minutes. They peak at 1 to 2 hours, and they have a duration of 3 to 6 hours. Then we have our short acting. This is just our regular insulin. Its onset is 30 to 60 minutes with a peak in 2 to 4 hours and a duration of 6 to 10 hours. Then we have our intermediate acting. This is our NPH. This has an onset of 2 to 4 hours, peaks 4 to 8 hours, and a duration of 10 to 18 hours. And then we have a long acting, which is our Glargine or Detamir. And this onset is 1 to 2 hours. It has no peak, and the duration is up to 24 hours. And you do want to remember your insulins. You will probably get a question about insulin. Then we have something called Dawn phenomenon. So this is reduced tissue sensitivity to insulin causing pre-breakfast hyperglycemia. Our nursing intervention is to increase the client's insulin dose or change in scheduling the insulin time. Then we have Somogyi's phenomenon. This is normal or elevated blood glucose levels at night. Then we see hypoglycemia at 2 to 3 a.m., causing an increase in counter-regulatory hormone. And by 7 a.m., due to this hormone, the glucose levels rebound and are increased. Signs and symptoms are early morning headache, night sweats, or nightmares. Our nursing intervention is to decrease the client's insulin dose and increase a bedtime snack or both.
Let's talk about the integumentary system. So the first thing we're going to talk about is wounds. And when it comes to wounds, we have a couple of different kinds of exudate. So things that it can leak, like fluid, pus, like things like that. So when we talk about exudate, we can have serous exudate. This is a clear or straw-colored. It is normal and part of the healing process. We have serosanguinous exudate, which is pink due to a small amount of blood mixed with serous drainage. This is also normal part of the healing process. We can have sanguinous. This is red because it's due to blood vessel trauma. It's uncommon in wounds. We can have a hemorrhage, which is frank blood leaking from a blood vessel. This is also uncommon and may require emergency treatment. And purulent, this is a yellow, gray, or green, and it's due to an infection. So that's important to know. They may ask you, if you see purulent drainage, what do you have to worry about? All right, so let's talk about pressure ulcers. So this is an impairment of skin integrity that can occur anywhere in the body. It's due to the skin being compressed on a bony prominence, restricting blood flow, and it has difficult time healing because of that. So the risk factors are skin pressure, skin shearing and friction, immobility, so our patients that might be bedbound or maybe they are in a chair most of the day. If they're not moving around, this is why we always want to try to reposition our patients so that we can reduce the risk of injuries if they are immobile. Malnutrition, incontinence, decreased sensory perception. So if they can't feel that there's pain there, then they might not know to readjust and things like that. When it comes to pressure ulcer staging, there are different stages. So a stage 1 is when the skin is intact, non-blanchable with local redness. That means when you push on it, that it doesn't blanch, so it doesn't turn white and then turn red again, so it just stays red. Then we have stage 2. This is going to be open, shallow, red, pink in color, no slough, intact, or an open blister. So just think like the top layer is just sheared away. Stage 3 is a full thickness skin loss, possibly visible fat, but no bone or muscle showing. Stage 4 is full thickness skin loss with bone, tendon, or muscle showing. And then unstageable is a full thickness with slough, so it looks like scabbing or eschar, which is black necrotic tissue. That would be unstageable because we can't see how deep it goes. So first we have shingles. This is also known as herpes zoster. It's due to a reactivation of varicella zoster in a patient with a history of chickenpox. Shingles is contagious to people who have never had chickenpox and to those who haven't been vaccinated against the disease. Signs and symptoms are an eruption occurs in a unilateral segmental distribution on the skin along the infected nerve. So it'll be unilateral, so it'll be on one side of the body and it will be distributed along the nerve pathway. We'll see fever, burning pain, pruritus. Our nursing interventions, patients should be on contact precautions. Patients should avoid scratching the area. And we can assess the seventh nerve because Bell's palsy is a complication. MRSA, signs and symptoms, it can appear as a folliculitis or furuncles. Culture and sensitivity to confirm MRSA. Our nursing interventions include contact precautions. It can spread by direct contact with infected skin. We're monitoring for signs and symptoms of infection, and we're administering antibiotics. Then we have cellulitis. This is an infection of the dermis and hyper. They're going to have pain, tenderness, edema, fever, arrhythmia, and warmth. Our nursing interventions are rest the affected area, apply warm compresses to promote circulation, and administer antibiotics. Then we have psoriasis. This is an autoimmune disease causing a rapid turnover of cells. There is no cure. We see shedding, a silvery plaque on rented skin. They might have pruritus, so itching, a yellow discoloration or thickening of the nails if they're infected, and they can have joint inflammation with psoriatic arthritis. Our nursing interventions are to avoid triggers, stress, trauma, infection. They'll use topical corticosteroids, sometimes phototherapy. We want to advise them not to scratch. Stress makes it worse. Medications are methotrexate. Sometimes they'll use that, and to avoid alcohol. Then we have Stevens-Johnson syndrome. So this is a medication-induced skin reaction, which occurs through an immunological response. Example, NSAIDs, antibiotics, and anti-seizure medications can cause this. It can be systemic involvement like the eyes, respiratory system, and it can result in blindness. So signs and symptoms, initially they'll have flu-like symptoms and erythema on the skin and mucous membranes. Then they'll start to have vesicle erosions and crusts on the skin. And then they'll have severe systemic symptoms, can cause ulcerations on the larynx, bronchi, and esophagus. Our nursing interventions are to discontinue the meds, administer antibiotics, corticosteroids, and supportive therapies. Now let's talk about burns. So when it comes to burn depth, we have superficial thickness burns. This is damage to the epidermis. They're pink, red with no blisters, and it heals in 3 to 6 days. We all know these types of burns. Get them on our hand, no blisters, it's just red, it burns a little bit. Then we have superficial partial thickness burn. So this is damage into the dermis. It'll be pink and red with a blister and edema, and it will heal in 10 to 21 days. We can then have deep partial thickness burns. This goes deeper into the dermis, red skin with white dry areas, and no blisters due to dead tissue that heals in 3 to 6 weeks. So an important thing to note is if it says a patient with blisters, we know that's superficial partial thickness burns. Again, we want to find the differences, right? So full thickness burn, this is destruction of the epidermis and dermis. It'll be waxy white, deep red, brown, or black, dry and hard skin. Healing takes weeks to months, and it can involve skin grafting. And then we have deep full thickness burn. So the injury extends to the muscle, bone, or tendons. Skin is black and hard. Healing takes months, and it involves skin grafting as well. So our priority nursing actions are to assess airway for patency, because always airway, breathing, circulation first. Administer oxygen if needed, obtain vital signs, initiate an IV line, and begin a fluid replacement. So again, this is our airway, this is our breathing, this is our circulation, because we want to prevent hypovolemia, shock, and preserve organ function. Elevate extremities if there's no fractures. Keep the client warm and place on NPO. Assess for signs and symptoms of infection. Urinary output is the most sensitive, non-invasive way to monitor cardiac output and tissue perfusion. Avoid IM or sub-Q medications because absorption through the soft tissue is not reliable. And proper nutrition is essential to promote wound healing. The basal metabolic rate is 40 to 100 times higher than normal with burn injuries, so they need an increase in calories. And it's a big increase, 40 to 100 times. So let's talk about the rule of nines to estimate burn percentages. So the head is 9%, the arm is 9%, legs are 18 each, torso's 36, and perineum is 1. And we want to remember that we have a front and a back. So the head is 9, but it's 4.5 for the front, 4.5 for the back. The arm is 9% each. So each arm is 9% and 4.5 for the front, 4.5 for the back. Legs are double the arms because they're pretty much twice as big. 9% for the front, 9% for the back. The torso is the largest area, so it's 36%. We have 18 for the front, 18 for the back, and then 1% for the perineum. Then we have something called the Parkland formula. So this determines the amount of resuscitation that's needed in 24 hours after a burn. So this is going to be 4 milliliters times the percent of the body burned. So again, and we find that percentage using rule of nines. And we give half of that milliliter amount in the first 8 hours. And then we give the remaining half over the next 16 hours. Let's talk about hematological and oncology. So first we have cancer. And this is a malignant neoplastic disorder that can spread throughout the body. It can be solid tumors or hematological cancers of the blood cells forming tissue. Metastases is when cancer moves from its original location to other locations, and it can do this in various ways. So first, it can do this by local seeding, which is distribution of shedding cancer cells, and it occurs in the local area of the primary tumor. It can use blood-borne metastases, so the tumor cells enter the blood. This is the most common cause of cancer spread. Or lymphatic spread, so the primary sites rich in lymphatics are more susceptible to early metastatic spread. Then let's talk about grading and staging of cancer. So first, grade 0, this is carcinoma in situ. Then we have stage 1. This is going to be, our grade is cells differ slightly from normal cells and are well differentiated. And the stage is that tumor is limited to tissues of origin, localized growth. So it has not metastasized. It's only in the tissue of origin with localized growth. When we move on to 2, these cells are abnormal and moderately differentiated, and there's just a limited local spread. 3, cells are very abnormal and poorly differentiated, and this has extensive local and regional spread. And stage 4, cells are immature, undifferentiated, and cells of origin are difficult to determine, and these have distant metastases. So warning signs of cancer, we can remember the acronym CAUTION, so changes in bowel and bladder habits, any sore that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion, obvious changes in warts or a mole, and nagging cough or hoarseness. To diagnose, a biopsy is the definitive means of diagnosing cancer. The tissue is then examined under a microscope. Let's talk about different types of treatment. So first, we have chemotherapy. This is going to kill or inhibit the reproduction of neoplastic cells and also kill normal cells in skin, hair, and GI lining. Then we have radiation. This destroys cancer cells with minimal exposure to normal cells. It's effective only for tissue in the direct pathway of the radiation beam. Side effects are local site changes. So they might have reddening of the skin. They might have pain in that area where they got the radiation. This is really just, they focus it on an area where they can shoot the beam in at it, where chemotherapy is going through your entire body and it's attacking normal cells. Nursing interventions, we want to wash irradiated area with water and soap daily. Do not remove the markings for the radiation beam, so they'll actually mark where they're shooting the radiation. Do not use powder, lotions, creams on skin at radiation site. Avoid any clothing or binding that will rub the skin too much at the radiation site, and we want to avoid exposure to the sun. And infection is a major cause of death for immunocompromised patients, so those on chemotherapy. We want to make sure they know to take proper precautions to not catch infections, and also the signs and symptoms of infections. All right, so nursing interventions for patients with a sealed radiation implant. So this is, they actually implant something with radiation in the body. So we want to place the client in a private room with a private bath, place a radiation precaution sign on their door, organize our nursing task to minimize exposure to the radiation source, because when we go in there, we'll be exposed. Nursing assignments to a client with a radiation implant should be rotated. Limit time to 30 minutes per care provider per shift. That's why we are doing all of our tasks as much as we can at once. Wear a dosimer film badge to measure radiation exposure. Lead shielding may be used to reduce exposure to radiation. The nurse should never care for more than one client with a radiation implant at one time. The nurse should never care. Do not allow a pregnant nurse to care for the client. Do not allow children younger than 16 years old or pregnant women to visit the client. Limit visitors to 30 minutes a day. Visitors should be at least 6 feet away from the patient. Save bed linens until the source is removed and dispose of the linens in the usual manner. Other equipment can be removed from the room at any time. If the radiation implant dislodges, we want to encourage the client to lie still. We're going to use long-handled forceps to retrieve the radioactive source. We're going to deposit that source into a lead container, contact the radiation oncologist, and document the occurrence in the actions taken. All right, so let's talk about patient education for those with cancers. So first, breast cancer. So this is an invasive and metastases by the lymph nodes. It increased the risk in females over 50 or those who have the BRCA1 or BRCA2 gene. We can teach our patients to do a breast exam. They can do this in the shower when the skin is slippery. We want to tell them to use the opposite hand to assess the breast. So our right hand to the left breast. So the right hand to the left breast. We want to use small circular motions in a spiral pattern to examine the entire breast, check for lumps, hard knots, thickening of the tissue. We can teach them to look in the mirror with the hands at the side, raise their arms up over their head, assess for any changes in shape or dimpling. We want to tell them to place their hands on the hips and press firmly to tighten the pectoral muscles and absorb for any changes in symmetry. And when lying down, they can also do this where they feel their breast with the opposite hand in a spiral motion. So post-mastectomy, if they remove the breasts, we're going to teach the patient to avoid overusing the affected arm during the first few months. Keep unaffected arm elevated to avoid lymphedema. Avoid strong sunlight on the affected arm. Do not let the affected arm hang dependently. We want to avoid constricting clothing. Have them avoid blood work and blood pressure on that affected arm. Education for testicular cancer. So this most often occurs between 15 and 40 years old, obviously in men. It can metastasize to the lungs, liver, bone, adrenal glands, and lymph nodes. When teaching patients about a testicular self-exam, it's best to have them assess right after the shower, gently lifting, feeling around. It should feel like an egg with no lumps. You can roll them around to feel for lumps and swelling and mass, and notify your doctor if there's any changes from 1 month to the next.
Let's talk about the gastrointestinal system. So things that we're going to monitor for within the gastrointestinal system. So the first one is a retroperitoneal hemorrhage. So signs and symptoms, we're going to see hypotension, back pain, something called Turner's sign. So this is a gray-blue discoloration of the flank seen in acute hemorrhagic pancreatitis. We could see a hematoma, and we'll see decreased distal pulses. We also want to monitor for a bowel perforation. So signs and symptoms, abdominal guarding, pain, distension, fever. They'll be pale, tachycardia, tachypnea. Dysphagia. This is a patient is at an increased risk of aspiration pneumonia because they have difficulty swallowing. Nursing interventions have evaluated by speech therapy. They may need thickened liquids, soft meals, put the head of the bed in high Fowler's 30 minutes post-meal, and have them swallow twice before taking another bite. As far as what we can see with stool and bowel movement, so we can have constipation. This will be small, dry, hard stool. We can have biliary obstruction, so the stool will be light gray or clay color. For ulcerative colitis, they'll have mucus in the stool. Pancreatitis, it will be a greasy, fatty, foamy stool. If they have an upper GI bleed, we'll see black tarry stool. A lower GI bleed will be bright red, and hemorrhoids will be blood on the surface of the stool. When we talk about constipation, our nursing interventions are going to be to ambulate the patient because this will increase peristalsis, put them on a high fiber diet, make sure they're drinking 2 to 3 liters of water a day, and have them on a bowel regimen. Let's talk about some different medical diagnoses you'll see within the gastrointestinal system. So the first one is GERD. This is better known as heartburn. They'll have heartburn, epigastric pain, dyspepsia, nausea and vomiting, pain swallowing. Our nursing interventions can include having them avoid irritants like coffee, chocolate, fried foods, carbonated drinks, and alcohol. And they can also be medicated with things like antacids, H2 receptor antagonists, or PPIs. Inflammatory bowel disease. So this is not to be confused. So this is not irritable bowel syndrome, IBS. So this is not that, okay? These are two different things. IBS is like a food intolerance, more that situation. Inflammatory bowel disease is an autoimmune condition. So the body is fighting the intestinal tract. We have 2 types, ulcerative colitis and we have Crohn's. So ulcerative colitis is the chronic inflammation leading to poor absorption of nutrients. It begins in the rectum and spreads upward. The colon becomes edematous and has these bleeding lesions form on the mucous membranes. So scar tissue causes diminished absorption of nutrients. There'll be periods of exacerbations and remissions like any real autoimmune disease. So symptoms, anorexia, malice, frequent bloody diarrhea and mucus, abdominal pain, fever, fatigue, weight loss. The thing to know for ulcerative colitis is this is only affecting the very first lining of the mucous membrane of the intestine. So it's only affecting that outside lining, and they get ulcers on this lining. And that's what's creating the blood in the mucus. So our nursing interventions in an acute phase, they may be NPO, need an IV, or parenteral nutrition. We restrict their activity to reduce intestinal activity. We monitor stool color, consistency, and for any signs of blood, monitor for hemorrhaging, perforation, or peritonitis. They may be on a low fiber diet during an exacerbation. They want to avoid alcohol, caffeine, raw fruits, raw vegetables, whole wheat, and milk. These patients may need surgery to create a stoma. The stoma should be pink. If it's purple or black in color, this indicates compromised circulation. When it comes to Crohn's, this inflammation can occur anywhere in the GI tract. for Crohn's, how we talked about with ulcerative colitis is just the outside lining, Crohn's can go all the way through. These ulcerations, it can create fistulas because it can be the entire membrane of the intestines. We can see leads to thickening and scarring, a narrowed lumen, fistulas, ulcerations, and abscess. Again, remissions and exacerbations. We can see things like fever, cramping after meals, weight loss, dehydration, abdominal distension, anorexia, nausea, vomiting, weight loss, anemia. And our nursing interventions are during an acute episode. It's the same as ulcerative colitis. And again, surgery may be necessary, but is avoided as long as possible because recurrence of the disease in the same region is likely to occur. Let's talk about diverticulitis. So this is an outpouching or herniation of the intestinal mucosa. It usually is discovered during a colonoscopy. Usually these people are asymptomatic and no treatment is needed. Diverticulitis, which is an inflammation of the diverticula, which can form an abscess. Signs and symptoms are left lower quadrant pain that increases with coughing, lifting, or straining. They may have an elevated temperature, nausea, or vomiting. They may have abdominal distension. They may have a palpable, tender rectal mass, and there may be blood in stool. Our nursing interventions are to provide bed rest during an acute phase, NPO status or clear liquids, monitor for perforation or hemorrhage, increase fluids to 2,500 to 3,000 milliliters a day, treat with antibiotics and a clear liquid diet, and introduce a fiber-containing diet gradually when the inflammation resolves. So then let's talk about peptic ulcer disease. So this is ulcerations in the mucosal wall. This is ulcerations in the mucosal wall of the stomach, pylorus, duodenum, or esophagus due to gastric secretions. Patients will complain of a gnawing, sharp pain in the left lower mid epigastric region that occurs 30 to 60 minutes after a meal. Food indigestion accumulates and causes the pain. Hematemesis is a common than melena, so coughing up blood is more common than passing blood or dark-colored blood in the stool. Our nursing interventions are to monitor for signs of bleeding. If they're bleeding, we want to get vital signs, check for signs of dehydration, shock, sepsis, and respiratory insufficiency. We want to maintain NPO and administer IV fluids, monitor H&H, administer a blood transfusion and medication as prescribed if needed. That would be if they're bleeding a lot. Administer small bland feedings during the active phase, administer antacids, anticholinergics, mucosal barrier protectants, and prostaglandins as prescribed, and educate the client on avoiding caffeine, chocolate, alcohol, NSAIDs, and aspirin. So those are our interventions if it's in the gastric area. Now, if it's in the duodenal area, we're going to see things like burning pain that occurs in the mid-epigastric area 1.5 to 3 hours after a meal that often awakes the client at night. They may have dark colored stool from blood passing in the stool, more so than coughing up blood, and pain is often relieved by the ingestion of food. Nursing interventions monitor vital signs, teach them to eat small meals frequently with a bland diet, encourage smoking cessation, and administer H2 receptor antagonists or PPI. Now let's talk about gastritis. So there's two types of gastritis. We have acute gastritis and chronic gastritis. So acute gastritis is a stomach inflammation due to contaminated food. This is going to have abdominal discomfort, anorexia, nausea, and vomiting, a headache, hiccuping, and reflux. Our nursing interventions are food and fluid that are withheld till symptoms subside. We can give them ice chips, clear fluids, and then solid food. When it's chronic gastritis, this is caused by ulcers, H. pylori, autoimmune, diet, medications, alcohol, smoking, or acid reflux. Symptoms include anorexia, nausea, vomiting, or belching, heartburn after eating, a sour taste in their mouth. They may have a B12 deficiency. And our nursing interventions are going to be NPO, monitor signs for hemorrhagic gastritis. So that would be hematemesis, tachycardia, hypotension, and avoid irritating foods and fluids. Then we have something called dumping syndrome. So this is a rapid emptying of gastric contents into the small intestines after gastric resection. So this is after a gastric bypass. Signs and symptoms. So it occurs 30 minutes after eating. We'll see nausea, vomiting, diarrhea, abdominal fullness and cramps, tachycardia, weakness, dizziness, and boregic sounds, which are loud, gurgling abdominal. So our nursing interventions, we want to teach patients that have had a gastric bypass to eat small meals and avoid fluids while eating. We can teach them to lie down after meals, avoid sugar, salt, and milk, and eat high protein, high fat, and low carb meals. Now let's talk about cholecystitis. So this is an inflammation of the gallbladder that may be acute or chronic. If it is acute, it's associated with gallstones, and if it's chronic, it's due to the inefficient bile emptying and inflammation of the gallbladder. Signs and symptoms we'll see are nausea, vomiting, flatulence, epigastric pain radiating to the right shoulder or scapula, which occurs 2 to 4 hours after fatty foods or a large meal. We can feel a mass in the upper right quadrant. They'll have right upper quadrant pain, guarding, and rebound tenderness. We can look for something called Murphy's sign. This is where they feel like they can't take a breath because of the pain when fingers are pressed on the hepatic margin. We can see tachycardia, elevated temperature, and dehydration. Now let's talk about obstruction in the gallbladder. So signs and symptoms are jaundice, dark orange and foamy urine, stratea and clay-colored stool, and pruritus. Our nursing interventions are NPO, NG decompression. For patients with chronic colitis, instruct them to eat small, low-fat meals. So now let's talk about cirrhosis. So this is destruction of hepatocytes, which leads to scar tissue formation. This is in the liver. Chronic causes are hepatitis C, alcoholism, non-fatty liver disease, and non-alcoholic steatohepatitis. Complications are portal hypertension due to flow obstruction, ascites due to congestive hepatic capillaries that lead to plasma leakage, coagulation deficits, coagulation defects, bleeding, esophageal varices, jaundice, the liver cannot metabolize bilirubin, portal systemic encephalopathy, and hepatorenal syndrome. So signs and symptoms, we can see a change in the level of consciousness due to failure of the liver to get rid of ammonia in the system. We can see ecchymosis, petechiae, and pulmonary erythema, leukopenia, dysrhythmias, fatigue, anemia, ascites, abdominal pain, dyspnea, and many others because most systems of the body are affected. And our nursing interventions are going to include elevating the head of the bed if they're having shortness of breath, provide vitamin supplements, restrict sodium and fluid intake, enteral and parenteral feeds, diuretic medications for ascites, weigh patients daily, monitor the level of consciousness, monitor for asterix. This is a coarse tremor characterized by non-rhythmic extensions and flexions in the wrists and fingers. We want to administer lactulose. This is a medication which facilitates the excretion of ammonia. Administer antibiotics. This inhibits the synthesis in bacteria and decreases ammonia production. Avoid opioids and sedatives. Teach the importance of alcohol abstinence. Monitor ammonium levels. And to help with pruritus, cut nails short, calamine lotion, cool wet cloths, avoid hot showers, and cholestyramine. Another diagnosis we may see is esophageal varices. So these are dilated veins in the submucosa of the esophagus. It's caused by portal hypertension associated with liver cirrhosis. And if they start bleeding, this is a medical emergency. Signs and symptoms are hematemesis, so coughing up blood, dark blood in the stool, melena,
ascites, jaundice, hepatomegaly and splenomegaly, dilated abdominal veins, and signs of shock. We're going to monitor for signs of rupture because this is life-threatening. Monitor vital signs, watch for orthostatic hypotension, monitor lung sounds, and note any presence of respiratory distress. Elevate the head of the bed, administer O2 to prevent hypoxia, monitor level of consciousness. They'll be on NPO status, receiving fluids with IVs, monitor H&H, administer clotting factor and blood transfusion as prescribed, insert an NG tube or balloon tamponade as prescribed, and instruct the client to avoid activities that will promote vasovagal response. So things like bearing down or straining during a bowel movement, we want to instruct them not to do that. Then we have appendicitis. So this is an inflammation of the appendix, and rupture can occur quickly, which leads to peritonitis and sepsis. So our signs and symptoms, so pain in the perineal area radiating to the right lower quadrant, pain near the belly button that radiates to the right lower quadrant. This is key. If you see that on an exam, that's appendicitis. Abdominal pain at McBurney's point, so this is another key thing to know. Abdominal rigidity, fever, nausea, vomiting, anorexia, abdominal guarding. Our interventions are going to be NPO, IV fluids to prevent dehydration. Do not palpate or apply heat to the abdomen. This increases the risk of rupture and peritonitis. Apply ice packs. And let's talk about hepatitis. So our goal is to increase blood supply, rest the inflamed liver, and reduce demands. So there's a few different stages in hepatitis. So we have the pre-ictic stage. This is the first stage of hepatitis. We'll see fever, malaise, fatigue, anorexia, pain, headache, and muscle aches. Then we have the icteric stage, and this is the second stage of hepatitis. We'll see signs and symptoms of jaundice, pruritus, elevated bilirubin, dark urine, clay-colored stool. And the post-icteric stage, they're starting to get better. So jaundice will decrease, urine and stool color return to normal, energy increases, pain subsides, and minimal GI symptoms. So now let's talk about types of hepatitis. So the first one is hepatitis A. This is spread through a fecal oral route, and it's a person-to-person contact with contaminated food or water and poorly washed utensils. Our incubation period is 2 to 6 weeks. Infection is another 2 to 3 weeks before and then 1 week after jaundice. And hepatitis A viral antibodies are found in the blood at an increased level will indicate infection. So our complications are fulminant hepatitis. This is a severe, acute, and often fatal hepatitis. Nursing interventions, we want good hand washing. When handling stool, we're just being careful, always using the precautions, treating municipal water supplies, hepatitis A vaccine. There is an immunoglobulin for travel or exposure. Then we have hepatitis B. This is spread through blood or bodily fluids. Increased risk for IV drug users, healthcare workers, those who work in prisons. Common in all age groups. Incubation period is 6 to 24 weeks. A hepatitis B surface antigen will disappear in 6 weeks. If not, then the patient is a carrier. And again, those complications are the fulminant hepatitis, chronic liver disease, cirrhosis, primary hepatocellular carcinoma. Our nursing interventions include hand hygiene, screening blood donors, testing pregnant women using our needle precautions, avoid sexual contact with hepatitis B positive individuals, hepatitis B vaccine, and a Hep B immunoglobulin for those who are exposed. Then we have hepatitis C. This is also spread through blood or bodily fluids. Increased risk for IV drug users, healthcare workers, those in prisons. Our incubation period is 5 to 10 weeks. Hepatitis C viral antibody will be found in the blood. And our complications are chronic liver disease, cirrhosis, and primary hepatocellular carcinoma. And again, nursing interventions, strict hand hygiene, needle precautions, screening blood. So now hepatitis D is interesting because it only occurs with the presence of hepatitis B. It's common in Mediterranean, Middle Eastern areas, has an intubation period of 7 to 8 weeks, and will see a hepatitis D antigen found in the blood. Our complications again are that fulminant hepatitis and chronic liver disease, and nursing interventions are prevention, which includes the hepatitis B vaccine, since hepatitis D also needs to coexist with hepatitis B. And then hepatitis E is a fecal and waterborne virus. Intubation period is 9 weeks. We'll see IgM and IgG antibodies to the hepatitis E viral found in the blood. Complications, there's a high mortality rate in pregnant women and fetal demise. And nursing interventions are strict hand hygiene and treating water supplies. Let's talk about home care instructions for those with hepatitis. So we want to teach patients good hand washing. Don't share bathrooms unless the client strictly adheres to personal hygiene. And this again is for hepatitis. This would be hepatitis A and hepatitis E. So the ones that are spread through fecal oral route. Washcloths, towels, drinking and eating utensils, toothbrushes, and razors must only be used by the patient. The patient may not prepare food for other family members. They should. For all types of hepatitis, patients should avoid alcohol and over-the-counter medications, particularly Tylenol and sedatives because they're hepatotoxic. The patient should increase activity gradually to prevent fatigue. The patient should consume small, frequent meals consisting of high carbs, low-fat foods. The patient cannot donate blood. Close personal contact such as kissing and sexual activity should be discouraged with hepatitis B until surface antigen tests are negative. And the client should carry a medical alert card noting the date of the hepatitis onset. All right, let's talk about pancreatitis. So this is when pancreatic enzymes escape into surrounding tissue. There are 2 types, acute, which occurs suddenly as one attack, or recurrent with resolutions. Signs and symptoms include abdominal pain, mid-gastric or upper, left quadrant radiating to the back. So that's important to know. The locations of the pain can really tell us what it is. So it's important to remember the locations of pain with certain diagnoses. Pain aggravated by fatty meal, alcohol, or lying in a recumbent position. This is also important, the fatty meal piece. You may be asked about that. Abdominal tenderness, weight loss, absent bowel sounds. This is also important to know. Something called Cullen's sign, which is discoloration of the abdominal and periumbilical area, and Turner's sign, which is blue discoloration of the flanks. Our nursing interventions include withholding food or fluid during an acute period and maintain IV fluids, administer parenteral nutrition for severe nutritional depletion, and an NG tube may be inserted if they are vomiting, have a paralytic ileus, or a biliary obstruction. Then we have chronic. This is a continual inflammation and destruction of the pancreas with scar tissue. Signs and symptoms are abdominal pain and tenderness, left upper quadrant mass. They may have stertoria and foul-smelling stools that may increase in volume. We may see weight loss, muscle wasting, and jaundice. And we may see signs and symptoms of diabetes. So our nursing interventions, we want to limit fat and protein intake, avoid heavy metals and avoid alcohol, administer pancreatic enzymes. We also want to look at, this is a lab, ALT and AST. These enzymes release when hepatic cells are injured. So 2 other diagnoses we may see related to the gastrointestinal system are a small bowel obstruction or a large bowel obstruction. So for a small bowel obstruction, we're seeing signs and symptoms of rapid onset nausea and vomiting, intermittent abdominal pain, and abdominal distension. For a large bowel obstruction, this is going to have a gradual onset, cramping and abdominal pain, abdominal distension, and complete constipation and no passing of gas. Nursing interventions for both of these are NPO, NG tube insertion, IV fluids, and managing pain. And the last diagnosis we're going to discuss is a paralytic ileus. This is a temporary halting of peristalsis for 24 to 48 hours after a bowel procedure.
and no bowel sounds will be auscultated. All right, so let's talk about different bowel procedures. So first we have gastric surgery, and our nursing interventions for this include following the gastric surgery, do not irrigate or remove the NG tube unless specifically prescribed because of the risk for distribution of gastric sutures. Monitor closely to ensure proper function of an NG tube to prevent strain on the anatomical site, and contact the healthcare provider if the tube is not functioning properly. We want to monitor respiratory complications that could be caused by pain at the insertion site. We want to encourage coughing and deep breathing, encourage ambulation, instruct the client about splinting the abdomen to prevent discomfort during coughing, administer antiemetics, administer analgesics, maintain NPO status, and the NG tube suction as prescribed, and advance diet from clear liquids to solids when prescribed and as tolerated by the client. When it comes to bariatric surgery, we want to teach the client to avoid alcohol, high protein foods, high in sugar and fat. We want to teach them to eat slowly and chew food, progress food types and amounts as prescribed, take nutritional supplements as prescribed, which may include calcium, iron, multivitamin, and B12, and monitor and report signs and symptoms of complications such as dehydration and gastric pain. Then we have a colonoscopy. So this is the lining of the large intestine is examined and biopsies can be performed. Nursing intervention is clear liquid diet day before with a colon cleanse given. There'll be NPO at midnight, and the patient is in a left side lying position with knees to chest while it's being performed. Then we have a colostomy. This nursing interventions are to keep liquid stool from leaking out. This causes skin irritation due to digestive enzymes. We want to change the bag. So this is a bag that's attached on the front of the patient where stool comes out of. They're creating a hole in the stomach into the intestines. We want to change the bag every 4 to 7 days. Increase fluid intake to prevent dehydration, and empty the bag when it's a third full. And then colostomy care, so we want to empty contents of the bag before removing it. Push skin away from the bag, wash the stoma using soap and water, but do not scrub. Inspect for redness, irritation, bleeding, and blisters, and pat dry. Measure the stoma using a measuring guide. With scissors, we cut along the measurement with 1/8 bigger than the stoma. Apply a barrier ring and apply a skin barrier and attach the stoma. All right, so let's talk about a paracentesis and thoracentesis. So these are the removal of fluid from the peritoneal cavity for a paracentesis, or the pleural space for a thoracentesis. It's performed at the bedside. Our nursing interventions are the patient is in an upright position at the edge of the bed with arms on the table for a thoracentesis. Vital signs and weights pre-procedure. Have the patient void if they're getting a paracentesis, and a dry sterile dressing at the puncture site, and measure fluid removal. We have total parenteral nutrition. For our nursing interventions, this is avoid stopping it abruptly as it can lead to hypoglycemia. We want to monitor signs and symptoms of hypoglycemia, such as polyphagia, polydipsia, and polyuria. Then we have something called an ERCP. This is an examination of the hepatobiliary system with an endoscope down the esophagus. Nursing interventions are NPO before the procedure, and post-procedure monitor for return of a gag reflex and for signs of perforation. And then we have enteral feeding. So this, we're looking for abdominal cramping can occur if the feed is too fast or too cold. Interventions are head of bed 30 to 45 degrees pre and post feed, tube flushes pre and post feed because we don't want it to clot, and assess bowel function. Okay, let's review the musculoskeletal system. So first we're going to talk about injuries. So risk factors include autoimmune disorders, calcium deficiency, falls, hypoglycemia, infection, medications, metabolic disorders, neoplastic disorders, obesity, and postmenopausal states. So we can have either a strain or a sprain. So the difference is that a strain is an excessive stretching of the muscle or tendon, whereas a sprain is a stretching of a ligament.
usually caused by a twisting motion. Signs and symptoms include pain and swelling for a sprain. Our nursing interventions for a strain are going to be cold and heat application, exercise, anti-inflammatory and muscle relaxant medications, whereas for a sprain, we're going to use something called RICE. So rest, ice, compression or cast, and elevation. So if you get a question asking about heat, remember that heat is only on a strain. So now let's talk about types of fractures. So we have a closed or simple fracture. This is skin over the fracture area may remain intact. Comminuted fracture, the bone is splinted or crushed with numerous fragments. Complete is bone is completely separated by a break into two parts. Then we have compression. This is fractured bone is compressed by two other bones. We have depressed, where the bone fragments are pushed inward. There's green stick. One side of the bone is broken and the other side is bent, most common in children. Impacted, so part of the bone is driven into another bone. Then we have incomplete, so the fracture line does not extend the entire width of the bone. We have oblique, which the fracture line runs on an angle. We have an open or compound. This is the bone is exposed to air through a break in the skin. For this, it's important we want to watch for infection, cover the wound with a simple sterile dressing. Then we can have pathological, which the fracture is due to weakness of the bone structure. And then we can have transverse, where the bone fracture is straight across. So signs and symptoms of a fracture include the 5 P's of a fracture. So pain, pallor, pulselessness, paresthesia, and polar, which is cold. They're going to have decreased muscle strength, an obvious deformity, crepitus, so if you feel it, you can feel it like creaking, and edema and muscle spasms. So then complications of a fracture, so things we want to look for. Make sure a complication is a fat emboli, a pulmonary emboli, compartment syndrome, infection, and a vascular necrosis. Our interventions include immobilizing the fracture. They may need an open or closed reduction, internal or external fixation, and traction or cast. All right, so let's talk about a fractured hip. So risk for hemorrhage. Nursing interventions are monitor for signs of delirium, maintain leg and hip proper alignment and prevent rotation, elevate the head of the bed 30 to 40 degrees for meals only, avoid weight bearing on affected leg, keep post-op leg extended, supported, and elevated when standing up, monitor neurovascular status of the extremity, and avoid crossing the legs in any activity that requires bending. So these are important. Complications of fractures. Complications of fractures. So we had discussed earlier a fat emboli. So this can occur after a fracture. So a long bone fracture is the greatest risk. Our signs and symptoms include restlessness, hypoxemia, changes in level of consciousness, tachycardia, hypotension, and shortness of breath. Our nursing interventions are give them oxygen if needed, IV fluids, monitor respiratory status, vital signs, and bed rest. Then we have compartment syndrome. So this is a pressure increases in a muscle group, usually after a cast has been placed, which decreased blood flow leads to tissue ischemia and neurovascular impairment. And after 4 to 6 hours of this syndrome, neurovascular damage is irreversible. So this is very important that we monitor for this. Signs and symptoms: paresthesia, limb pain, pressure, pallor, pulselessness distal to the area, and paralysis. For nursing interventions, we want to notify the doctor. They're probably going to have to do a fasciotomy to relieve pressure buildup or loosen the restrictive cast.
and then avascular necrosis. So when a fracture interrupts blood supply to the bone, which can result in bone death. Okay, so let's talk about some nursing interventions related to the musculoskeletal system. So first we have Buck's traction. This alleviates muscle spasms and immobilizes the limb. Our nursing interventions include ensuring proper body alignment. Weights hang freely and don't touch the floor. Do not remove weights without a doctor's order. Ensure that pulleys are not obstructed, and elevate foot of bed and check ropes for fraying. Then we have cast care. So teaching is going to be to keep the cast elevated, allow 24 to 72 hours for a cast to dry, handle a wet cast with palms of hands, turn the extremity every 1 to 2 hours to allow circulation, use a hair dryer on a cool setting to help with the drying process. Do not insert any object into the cast to relieve itching. This is very important. Monitor for signs of infection, and keep the cast clean and dry. Our nursing interventions are to monitor the casted extremity for circulation impairment. So we're looking for pain, discoloration, numbness, swelling, coolness, tingling, and diminished pulse. Then when it comes to crutches, so we want to make sure the crutches are measured properly. They should be 2 to 3 finger widths between the axilla space and the arm piece. Elbows should be flexed 20 to 30. Should stand on the patient's affected side when ambulating. Do not rest axilla on the axillary bars, and stop ambulation if numbness or tingling occurs in hands or arms. When assisting the client with crutches to sit to stand, we place the unaffected leg against the front of chair. We move the crutches to the affected side. Grasp the arm of the chair with the hand on the unaffected side. When lowering self into the chair, flex the knees of the unaffected leg while placing the affected leg straight out in front. Reverse the steps to remove from sitting to stand. All right, so let's talk about going up and down the stairs. The client moves the unaffected leg first. The client moves the affected leg and the crutches up. Going down the stairs, the client moves the crutches and the affected leg down, and then the client moves the unaffected leg down. So let's talk about some medical diagnoses related to the musculoskeletal system. So first we have rheumatoid arthritis. This is an autoimmune disease that leads to chronic systemic inflammation, destruction of connective tissue, and synovial membranes in the joints, and ultimately leads to dislocation and permanent deformity of the joints. Signs and symptoms include inflammation of the joints, pain and stiffness in the morning greater than 30 minutes, muscle atrophy, spongy joints, and weight loss. Our nursing interventions include rheumatoid factor blood tests to confirm diagnoses, range of motion exercises using hot and cold, rest and activity balance, prevent flexion of contractures, avoid weight bearing on inflamed joints, use chair with a high back, and a small pillow when laying down. Then we have osteoarthritis. This is a progressive deterioration of articular cartilage in the peripheral and axillary joints, mostly on weight-bearing joints, hips, knees, hands. The cause is unknown, though it could be trauma, aging, obesity, genetics, and smoking. Signs and symptoms are pain that increases with activity. So these are like the key things. So rheumatoid arthritis, pain and stiffness in the morning for greater than 30 minutes. Key point. For osteoarthritis, pain that increases with activity and decreases with rest and increases with temperature change. You'll also see Heberden's or Bouchard's nodes, so here is another key point, and you'll also see crepitus. Our nursing interventions for osteoarthritis are pain and corticosteroid meds, avoid flexions of knees and hips, avoid large pillows when laying, apply cold packs when joint is inflamed, and balance activity and rest and limit activity when in pain. Then we have osteoporosis. So this is bone demineralization leading to fragile bones and risk for fractures. Risk factors include smoking, early menopause, alcohol use, family history, being a female, increased age, low calcium intake, sedentary lifestyle, thin and small frame, European or Asian race. Signs and symptoms are possibly asymptomatic. They might have back pain with palpitations after lifting, bending, or stooping, pelvic or hip pain, balance problem, a decline in height, or kyphosis, and there is a risk for pathological fractures. Our nursing interventions are to move them gently, assist with ambulation if unsteady, gentle range of motion exercises, and a firm mattress. Now let's talk about amputation of a lower extremity post-op. So this is going to be surgical removal of a limb, and nursing interventions are monitored for bleeding and drainage, explain phantom limb syndrome or phantom limb pain, do not elevate residual limb on pillow. In the first 24 hours, elevate the foot of bed to reduce edema. After, keep the bed flat to prevent flexion contractures. And after 24 to 48 hours, put the patient in a prone position to stretch the muscles. Then we have gout. This is a buildup of urate crystals in the joints due to high uric acid in the body. We're going to have painful joints, something called tophi, which are hard nodules, pruritus, renal stones, and inflammation of the small joints, specifically the big toe. If someone is reporting inflammation of their big toe, gout is something we should be looking at. Nursing interventions, so a low purine diet, so we're avoiding organ meats, wines, aged cheese, and alcohol. High fluid intake of 2,000 milliliters a day. Monitor joint range of motion, bed rest during painful attacks, and heat and cold applications for pain. Okay, let's review the immune system. The first thing we're going to talk about is HIV. Our nursing interventions for this are standard precautions. HIV is only spread when non-intact skin is in contact with patients' blood, breast milk, semen, or vaginal secretions. We want to protect these patients from infection and always using aseptic technique for all procedures. HIV testing, so we're looking at CD4 and T cell count, which is normally between 500 and 1600. In HIV, it will drop below 500 and in some cases lower than 200. We may do a viral culture of the patient's blood, looking at viral load testing, P24 antigen assay. We have an oral testing for HIV where a device is placed against the gums, and a home test. Then we have AIDS. So this is a viral disease due to HIV, high risk for infection and malignancy, an incubation period of up to 10 years. Signs and symptoms include low white blood cells, platelets, CD4, along with high CD8, IgG, and IgA. We can see weakness, fever, weight loss, which is called a wasting syndrome, leukopenia, night sweats, infections. Neoplasms such as Kaposi sarcoma occur in immunocompromised individuals. It's a slow-growing tumor. And they can also have the presence of fungal, viral, and bacterial infections. Are high risk, such as IV drug users, patients receiving blood products, healthcare workers, and babies born to infected moms. Our nursing interventions are oxygen as needed, maintain fluid and electrolyte imbalance, monitor for infections, using standard precaution and meticulous skin care. Let's talk about anaphylaxis. So this is an immediate hypersensitivity reaction with release of histamine. We'll see angioedema, dizziness, paresthesia, pruritus, urticaria, narrowing of the airway, wheezing, stridor, shortness of breath, respiratory arrest, hypotension, tachycardia, cardiac arrest, abdominal pain, nausea, and vomiting. Nursing interventions always are ABCs. So first is making sure there's a patent airway. They can have that angioedema, which can close up the airway. We may need to give them supplemental oxygen. They may need IV normal saline infusion. And we want to be giving them the antidotes, whether it's Benadryl or epinephrine. Disease. So this is an infection due to Borrelia burgdorferi from a tick bite. So there are 3 stages. The first stage, we're going to see symptoms that occur several days to months following a bite. A ring-shaped rash may occur anywhere on the body. This is key. They give you something that's talking about a ring-shaped rash, you want to be thinking Lyme disease. They have flu-like symptoms such as headache, stiff neck, muscle ache, and fatigue. The second stage occurs several weeks following the bite. There'll be joint pain, neurological complications, and cardiac complications can occur. And the third stage, large joints become involved and arthritis progresses. Our nursing interventions are to remove the tick, complete a blood test for diagnoses 4 to 6 weeks after the bite for reliability, administer antibiotics, teach patients to avoid woody areas, teach them to wear long sleeve tops and pants when outside, and use tick repellent. So then we have different types of immunoglobulins. So we have immunoglobulin A. This gives us viral protection. We have immunoglobulin D, which has an unknown function. Immunoglobulin E is our allergy and parasitic infestation protection. IgG is our secondary antibody protection, and IgM is our primary antibody protection. So now let's talk about a couple autoimmune diseases. We've talked about some other ones in their specific systems that they're related to, but we're going to talk about systemic lupus. This is a chronic progressive systemic inflammation which causes the organs to fail. The cause is unknown, but it's thought to be genetic. Symptoms are a mylar rash on the face. This is also called a butterfly rash. This is a key point. If you see this in a question, the answer is most likely going to be lupus. Dry rash on the upper body, fever, weakness, weight loss, photosensitivity, joint pain, red palms, anemia. They'll have a positive ANA blood test and an elevated ESR and C-reactive protein. So our nursing interventions is we want to monitor for skin integrity, mild soap on the skin, frequent oral care, high vitamin and iron diet, conserve energy and avoid direct sunlight, topical corticosteroids, and monitor BUN and creatinine levels to watch for renal impairment because they do have that organ failure. Scleroderma. So this is similar to lupus. It causes inflammation, fibrosis, and sclerosis of connective tissue, and there is no cure. Patients will have pain, stiff muscles, pitting edema, tight, shiny, thick, and hard skin, dysphagia, and contractures. For nursing interventions, we want to encourage activity as tolerated, maintain constant room temperature, provide small meals, eliminate spicy foods, caffeine, and alcohol. And we want to remember that renal crisis is a life-threatening complication and causes hypertension due to narrowing of the blood vessels going to the kidney. Assessments, so regular kind of vital signs and lab values. So the first is our adult vital signs. Heart rate normally 80 to 100, respiratory 12 to 20, blood pressure 110 to 120 over 60, and temperature 98.6 or 37 degrees Celsius. Then when we talk about serum electrolytes, so how I remember these is first we have potassium. And when I think of potassium, I think of bananas. And when I go to the store and I buy a bunch of bananas, there is between 3.5 and 5 bananas in a bunch. And we want to make sure that we definitely remember potassium because when patients are outside of the normal range, we can see cardiac irregularities. It's really pretty much the most important electrolyte to be monitoring. It's always our priority, so it's really important we remember that. So then when we talk about sodium, so when I think of sodium, I think of like fast food, burger places, like things that have a lot of sodium on French fries, like salt. I'm thinking salt, like salty food. So when you go to a place that has salty food, you're going to spend around $13.50 to $14.50. So I remember it as $135 to $145. So that's just how I remember it, but that's me. You might find a different way. Then calcium. So when I see calcium, CAL, I think call 911. It must just be the psych nurse in me. But when we call 911, that's very close to 8.5 to 10.5. So that's how I remember that. Then we have chloride. So when I think of chloride, I think of chlorine and I think of a pool. And I personally only like to swim in a pool when it's really hot. So like 95 to 105 degrees, that's when I'll go swimming. So that's how I remember that one. Then we have magnesium. And I just remember that's 1.5 to 2.5. Again, you're probably not going to get a question about magnesium. If you're going to get a question about electrolytes, it's going to be sodium or potassium. And then phosphorus is 2.5 to 4.5. Now when we talk about blood values, red blood cells 4.5 to 5, white blood cells 5 to 10. Anything higher than this can indicate an infection. Neutrophils 60 to 70, lymphocytes 20 to 25, monocytes. I'm not going to read through all of these, but these are the labs you should know. The big ones, I would say, you're not going to get asked on NCLEX about neutrophils and lymphocytes and monocytes. You might get asked about red blood cells, hemoglobin or hematocrit, and white blood cells related to infection. All right, so then we have cardiac markers, and the things that are important to know about this is troponin is very important. You probably won't get asked about these other ones, but you might get asked about troponin in relation to an MI. Okay, and then acid-base balance. So when we're figuring out acid-base balance, and we'll go over this a little bit later, these are our normal values. Anything outside of this can indicate a problem, and we'll go over how to do that in a little bit. But a normal pH is 3.5, 7.35 to 7.45. Normal CO2 is 35 to 45. Normal HCO3 is 24 to 26. PaO2 is 80 to 100, and SaO2 is greater than 95. Those are our normal values. When it comes to chemistry values, again, these are our normal values for chemistry. Things that I would make sure you definitely know for NCLEX is the glucose value. So 70 to 110 is the normal. You probably aren't going to get asked anything on the rest of these, but you may, so they're good to know. But I would definitely know the glucose. Anticoagulation therapy, these I would know. You may get a question about heparin or warfarin or something like that. So PT normal is 20 to 36 seconds on heparin. We want it to be 1.5 to 2 times the normal. Our PT 9 to 11 seconds, and an INR of 0.9 to 1.8, but 2 to 3 if on warfarin. And then our therapeutic drug levels. Things to know for NCLEX, definitely the digoxin, definitely the lithium levels. And I would say that's probably the need to know, but you have the rest of these here to look at as well. Then also vancomycin, I would note that one. Adventitious lung sounds. So the different types of lung sounds you might hear when doing an assessment. The first one is going to be crackles. So these are fine, short, interrupted cracking sounds. Alveolar rails are high-pitched. Sound can be stimulated by rolling a lock of hair near your ear. So if you take your hair and kind of crinkle it near your ear, that's the sound that crackles will be. It's best heard on inspiration, but can be heard on both inspiration and expiration, and can be cleared by a cough. The sound comes from air passing through fluid or mucus. Then we have gurgles or rhonchi. This is a continuous, low-pitched, coarse, gurgling, harsh, loud sound with a moaning or snoring quality. It's the best heard on expiration. And this is air passing through a narrow air passage as a result of secretion, swelling, or tumor. Then you might hear a wheeze. So this is a continuous high-pitched squeaking musical sound. That's the key. If in the question they're asking you about a musical sound, it's most likely going to be a wheeze. Heard on expiration, not altered by coughing. And this is air passing through a constricted bronchus as a result of secretion, swelling, or tumor. Then we have a pleural friction rub. This is a superficial grating or creaking sound heard during inspiration and expiration. And this comes from rubbing together of inflamed pleural surfaces. Then we have stridor. This is a harsh, high-pitched, that's the key word here, breathing due to obstruction in the upper airway. And again, that's from an obstruction in the upper airway. All right, so let's talk about conversions. These you definitely need to know. You may get questions about this on NCLEX related to medication dosing, fluid
balances if someone is on a fluid restriction, how many cups of something can you give, or weights, or all of those things. So important to know is that one teaspoon is 5 mLs, 1 tablespoon is 3 teaspoons. This is important to know. You may get a medication question related to that. Also, other ones that are important, that 1 ounce is 30 mLs. That is important. That 1 cup is 8 ounces. 1 kilogram is 2.2 pounds. I'd probably say you should know that 1 gram is 1,000 milligrams. And those are probably the real important ones. Maybe that 1 pound is 16 ounces. You might get something on that. And 1 milligram is 1,000 micrograms, or 0.001 grams. So make sure you know these because you may get questions related to medication dosing. All right, so medication calculations. So the first one is going to be the amount to administer. So we want to take the dose and put it over what we have, and that's going to give us the amount to administer. So in order to do that, we're going to plug in, so X mLs, so the amount to administer, equals the unit dose over the unit concentration equals milligrams over milligrams. Then we can look at flow rate calculations. So to do this, we're putting the rate equals the amount of milliliters over per hour. And our drip rate equals the ordered volume times the drip rate over time in minutes. And then we have infusion time. So infusion time is the total volume to be infused over milliliters per hour being infused. And those are medication calculations. And I can make another video on medication calculations if you guys want to go more in depth with this. But again, this is just a review. So these are your medication calculation equations. All right, so we just went over in depth fluid and electrolytes. This is a review that comes in the packet. That was a free study guide that you can also get, so you guys can put them together, whatever you feel like is going to help you. To add on to what we just talked about, we have different types of fluids. So the first type is called intravascular. So this is a fluid inside a blood vessel. And we have intracellular, fluid inside a cell. Mostly bodily fluids are inside a cell. And we have extracellular. So this is fluid outside the cell, which includes interstitial fluid between cells, blood, bone, connective tissue, and water. Then we have different types of solutions. So we have an isotonic solution. These are things like 0.9% normal saline, D5W, and lactated ringers. They have no osmotic force, cells don't swell or shrink. Then we have a hypotonic solution. This is, I like to think of it as lower than our isotonic, so 0.45 normal saline or 0.33 normal saline. And these have a lower concentration of salt, which causes water to enter the cell. We have to watch for edema with these. Then we have hypertonic. So I like to think of these as higher than our isotonics. So this is 3% normal saline, 5% normal saline, D10W, D5W with 1/2 normal saline, D5 lactated ringers, and D5 normal saline. These are more concentrated solutions, so they have more solute than water, and water is removed from the cell, so the cells shrink. Then we have colloid, so this is dextran or albumin. These are plasma expanders. Fluid moves from interstitial to intravascular compartment, and this is given in severe hypovolemia. Patients with severe nausea and vomiting are at risk for electrolyte imbalances. We want to keep that in mind now that we're talking about electrolyte imbalances. So for electrolytes, so let's talk potassium imbalance. And we can remember the normal range of potassium as potassium is found in bananas. So when you buy a bunch of bananas at the store, you have between 3.5 to 5 bananas per bundle. So when we talk about
hypo, that means low. So that's going to be anything less than 3.5. And when we talk hyper, that's high. So that's anything greater than 5. And those are our parameters. So what are some things that we are going to see? For hypokalemia cardiovascularly, we're seeing a thready, weak, irregular pulse. Now, if we look over to hyperkalemia, we're actually seeing the same thing. So that really isn't something that we should memorize because it's not going to be something that differentiates between the two. Now, if you look also cardiovascularly, again, we're seeing a decrease of blood pressure for hyperkalemia, and we're seeing orthostatic hypotension for hypokalemia. Pretty similar. Now, when we talk about respiratory, with hypokalemia, we're seeing shallow, ineffective respirations due to skeletal muscle weakness. When we look at hyper, we're seeing profound weakness of skeletal muscles leading to respiratory failure. Again, these are pretty similar. So let's keep moving on. So neuromuscularly, with hypokalemia, we're seeing anxiety, lethargy, confusion, and coma, skeletal muscle weakness, leg cramps, loss of tactile discrimination, paresthesis, and deep tendon hypoflexia. With hyperkalemia, we're seeing muscle twitches, cramps, paresthesia, and late we're seeing profound weakness, ascending flaccid paralysis in arms and legs become affected when potassium levels become lethal. Okay, so again, we're seeing those paresthesias, we're seeing loss of the tactile discrimination, we're seeing muscle weaknesses, and we're seeing deep tendon hypoflexia and flaccid paralysis of arms and legs. So those are all pretty similar. The one thing that really sticks out to me is muscle twitches and cramps for early signs of hyperkalemia. So I would definitely memorize that. That's something different. And because it's so specific, the deep tendon hypoflexia, although that is similar to the muscle weakness and flaccid paralysis and things like that, because it's so specific, I would also memorize this for the hypokalemia. So let's keep moving on. So gastrointestinally, for hypokalemia, we're going to see decreased motility, hypoactive bowel sounds, nausea, vomiting, constipation, abdominal distension, and paralytic ileus. Now, if we look over gastrointestinally for hyperkalemia, we're seeing increased motility, hyperactive bowel sounds, and diarrhea. Okay, so here we go. Here is big difference number one. Okay, so we want to memorize those gastrointestinal signs for hypo versus hyper. Now, the thing that makes this nice is that with hyper, everything is increasing. We're having increased motility, hyperactive bowel sounds, and diarrhea. Things are moving. With hypokalemia, things are slowing down. We have the hypoactive, the nausea, the paralytic ileus. So things are really slowing down on this side and they're speeding up over here. Okay. So when we talk about EKG changes, there are some important things to remember here as well. So we can see for hypokalemia, we have shallow, flat, inverted T waves. This is important because it's the opposite of the tall peaked T waves we're going to see in hyperkalemia. So again, the thing that is nice is hyper is going up, hypo is going down. So this is easy to remember. Now we are also going to have a prominent U wave in hypokalemia. So just remember that one as well. And you can remember that in hyperkalemia, we're going to see those flat P waves, a widened QRS, and a prolonged PR interval. So you want to definitely remember those EKG changes. So let's talk about risk factors. So anything that is hypokalemia is a potassium loss. So remember, we're low. Our K is low. So this could be from an inadequate intake. Maybe they're fasting or NPO. It could be potassium moving into the cell from hyperinsulinism or alkalosis. It could be a dilution of serum potassium, maybe from IV therapy with potassium deficient solutions or water intoxication. When we're talking about hyperkalemia, medications like ACE inhibitors, NSAIDs, potassium-sparing diuretics can all increase our potassium. Excessive potassium intake can also increase it. Kidney disease or dialysis with decreased potassium excretion, Addison's disease, tissue damage, acidosis, hyperuricemia, and hypercatabolism. So another thing that really sticks out to me is hyperkalemia, you're going to have acidosis, and hypokalemia, you're going to have alkalosis. So that might be something important to remember, those opposites. Now, see, if you're looking at this whole list and you're trying to memorize each side, it's going to be really hard. It's a lot of information. So what we want to do is pick out the key differences. And it may also be good to memorize that hyperinsulinism is for hypokalemia, where hyperuricemia and hypercatabolism is for hyperkalemia. All right, so our nursing interventions, we're talking about hypokalemia. We're going to do oral potassium supplements, liquid potassium chloride, potassium retaining diuretics, any of these, whatever the doctor orders. Potassium is never administered by IV push, IM, or subcutaneous routes. IV potassium is always diluted and administered by an infusion device. So make sure you know that. If there's ever an answer that's asking you to give potassium IV push, that is wrong. Hyperkalemia, things we're going to do for our nursing interventions is monitor EKG, restrict potassium diet, avoid salt substitutes, discontinue IV or PO potassium, prepare potassium secreting diuretics, prepare client for dialysis. This is going to bother me. Diuretics, okay. Prepare client for dialysis, prepare IV calcium gluconate and IV sodium bicarb. And then just to remember, foods with potassium, because this might be something they ask you on NCLEX. Your patient has hyperkalemia, which food would you not give them? So foods with potassium: avocado, banana, carrots, fish, oranges, potatoes, pork, beef, spinach, and tomatoes. And also just remember that potassium and sodium are the opposite. And when we talk about sodium, you will see that more. The signs and symptoms are reversed.
Okay, now let's talk about a sodium imbalance. So we're going to talk about hyponatremia, which is a low sodium, less than 135, and hypernatremia, which is greater than 145. So when we have hyponatremia, we're going to see low specific gravity, and when we have hypernatremia, we're going to see high specific gravity. So let's look at the different signs and symptoms based on different systems within the body. So in the cardiovascular system, we'll talk about hyponatremia first. So if someone is normovolemic, meaning they have a normal amount of blood volume, they'll have a rapid pulse with a normal blood pressure. If they're hypovolemic, meaning that they have a low blood volume, there'll be a thready, weak pulse, hypotension, flat neck veins. And if they're hypervolemic, you'll see a rapid bounding pulse with normal or elevated blood pressure. They're going to have shallow and ineffective breathing, but this will be a late sign. You'll see skeletal muscle weakness and decreased deep tendon reflexes. Central nervous system, you'll have headaches, confusion, seizure, coma, and personality changes. Gastrointestinal, increased motility, increased bowel sounds, nausea, abdominal cramps, and diarrhea. Renal will be increased renal output, and integumentary will be dry mucous membrane. So again, when we are looking at the signs and symptoms between hyponatremia and hypernatremia, what we want to do is pick out the differences, and that's what we want to memorize, because if we get a question on it, they're going to be asking about something that's different. So if we look over at hypernatremia, we can see heart rate and blood pressure will be dependent on vascular volume, so not much to differentiate there. Respiratory, we'll see pulmonary edema if hypervolemic, so that is something different. Granted, it's only if they're hypervolemic, but again, pulmonary edema. Neuromuscular, we'll see muscle twitches, irregular muscle contractions, and then late signs will be muscle weakness and decreased deep tendon reflexes. So we want to remember that if it's an early sign, we're going to see those muscle twitches and muscle contractions. Those are things we're not going to see in hyponatremia. Central nervous system, we're seeing altered cerebral function. Normal volemia or hypovolemia, you might have agitation, confusion, and seizures. Hypervolemia, lethargy, stupor, coma. So again, all of those are very similar to hyponatremia. So there's really no kind of differences to memorize. We can remember that with hyponatremia, we have shallow and ineffective breathing as a late sign. That's important. Gastrointestinally, we'll have extreme thirst, so that is different. So we want to remember that. And then if we come over to hyponatremia, we can see increased motility, bowel sounds, nausea, abdominal cramps, and diarrhea. So again, this is different. So those GI symptoms are very different. So knowing those. Again, here's a big one to know the difference. So renal, if it's hypernatremia, we're having decreased output, but if it's hyponatremia, we're having increased output. So that might be something you're asked about. And integumentary, dry and flushed skin, dry, sticky mouth and mucous membranes, and edema. So the dryness is the same for both, but the difference is you might see edema. So memorize that. So let's talk about risk factors. So with hyponatremia, your risk factors include increased sodium excretion. This could be from diaphoresis like a high fever, diuretics like loops or thiazides, diarrhea, vomiting, drains, and G-tube suction, and decreased excretion of aldosterone. You can have SIADH, adrenal insufficiency, inadequate sodium intake from fasting or NPO, kidney disease, or heart failure. When it comes to risk factors of hypernatremia, could be increased sodium intake, oral sodium intake, IV fluids with sodium, hypertonic IV solutions, or loss of fluids through fever, diarrhea, diabetes insipidus, excessive sweating, and infection. So important things to know is for diabetes insipidus, you're going to see the hypernatremia, and for SIADH, you'll see the hyponatremia, as well as adrenal insufficiency and kidney disease. And also knowing increased sodium intake is going to give you hypernatremia, which would make sense because it's too high. And increased sodium excretion is going to give you hyponatremia because it's too low. So what are our nursing interventions? For hyponatremia, we're going to administer IV sodium chloride. We'll give diuretics if it's due to hypervolemia, because remember, there's too much fluid in the vascular system. It's diluting the blood essentially and making you hyponatremic. So that's why if we give diuretics, we can get rid of some of that fluid and come back to a normal amount of sodium. Daily weights, safety, orthostatic hypotensions because they're at risk for fall, airway protection, NPO if lethargic, limit water intake if hypervolemic, and teach about foods that contain salt. For hypernatremia, if due to fluid loss, we'll administer IV, because if you're losing fluid, that means that there's an increased amount of sodium in your blood because there's less fluid. If due to inadequate renal excretion, give diuretics that increase sodium loss and restrict sodium and fluid intake per order. Foods with sodium are bacon, butter, canned food, cheese, milk, condiments, salt, and bread. And potassium and sodium are opposites. So usually when our potassium is high, our sodium is going to be low, and vice versa. All right, so let's talk about calcium imbalances. So we have hypocalcemia, which is less than 9, and hypercalcemia, which is greater than 11. And the way I remember these numbers is when I think calcium, I think call, and call 911. So that's how I remember that. But so signs and symptoms. So again, we're looking for differences. So for hypocalcemia, we're seeing a decreased heart rate, decreased blood pressure, and decreased peripheral pulses. So this right here, decreased heart rate, that is a key point, because if we come over to hypercalcemia, we can see that there's an increased heart rate at first, and then it does turn into bradycardia. When we look at calcemia, we're seeing decreased peripheral pulses, but when we look at hypercalcemia, we're seeing bounding. Now let's talk about neuromuscular. So for hypocalcemia, we're seeing irritable skeletal muscles, twitching, cramps, tetany, and seizures. So this is a big thing because if we look over at hypercalcemia, we're seeing profound muscle weakness, decreased deep tendon reflexes. So again, they're the opposite. Hypocalcemia, we're going to have painful muscle spasms in calves or feet during periods of inactivity, paresthesia followed by numbness, may affect the lips, nose, ears, and limbs, increased deep tendon reflexes, anxiety, irritability. So these neuromuscular signs are really important to know because they're different. When it comes to gastrointestinal, same thing, very important to know because they're the opposite. With hypocalcemia, we're seeing increased motility, bowel sounds, abdominal cramps, diarrhea. With hypercalcemia, we're seeing decreased motility and bowel sounds. So this is important. And the big thing to know is that there's something called Trusso's and Chauvet-Stokes sign. For hypocalcemia, because everything is going up, increased deep tendon reflexes, increased motility, increased bowel sounds, twitches, cramps, tetany, seizures, all of that increase of those symptoms is going to give you something called a positive Trousseau sign, which is a carpal spasm induced by inflating a blood pressure cuff above the systolic pressure for a few minutes. So you put a cuff on the patient's arm, you pump it up, and they're going to have a carpal spasm of their leg. A positive Chauvet-Stokes sign is contraction of the facial muscle in response to a light tap over the facial nerve in front of the ear. So that is important to know. EKG changes we're going to see. So for hypocalcemia, we can see prolonged ST interval and prolonged QT interval. For hypercalcemia, we see a shortened ST segment and a widened T wave. Risk factors for hypocalcemia include inhibition of calcium absorption in the GI tract, increased calcium excretion through wound drain, diarrhea, steatorrhea, kidney disease, if they're in the diuretic phase, and conditions that decrease the ionized fraction of calcium. For hypercalcemia, our risk factors include increased calcium absorption, decreased calcium excretion, kidney disease, thiazide diuretics, hyperparathyroidism and hyperthyroidism, malignancy leading to bone destruction from tumors, and hemoconcentration. Our nursing interventions for hypocalcemia are to give calcium supplements, either PO or IV, administer vitamin D and aluminum hydroxide, initiate seizure precautions, and consume foods high in calcium. Our nursing interventions for hypercalcemia are to DC the thiazide diuretics or IV PO calcium, EKGs and neurostatus monitoring, loop diuretics, encourage fluids, and restrict dietary calcium. And a patient with a calcium imbalance is at risk for fractures, so move the client carefully and assist with ambulation. Foods with calcium include cheese, milk, spinach, yogurt, tofu, sardines, and greens. And calcium and phosphate are opposites, so if calcium is high, phosphate will be low. Okay, so let's talk about magnesium imbalance. So we have hypomagnesemia, which is less than 1.3, and we have hypermagnesemia, which is 10.5 or higher. So again, we're looking for differences. So for hypomagnesemia, we look at the cardiovascular. So this is important because we have tachycardia and hypertension. When we go over to hypermagnesemia, we have bradycardia and hypotension. So they're opposites. So that's important to know. Now, if we look at respiratory, for hypomagnesemia, we have shallow respirations. And for hypermagnesemia, we have respiratory insufficiency when the skeletal muscles of respirations are involved. Okay, not many differences. When we go back to hypomagnesemia, we're seeing neuromuscularly twitches, paresthesias, positive Trousseau's and Chauvet-Stokes sign, hyperreflexivia, tetany, and seizures. So these are all important because these are different than hypermagnesemia, which is going to have diminished or absent deep tendon reflexes and skeletal muscle weakness. In the central nervous system of hypomagnesemia, we're seeing increased motility and hyperactive bowel sounds and abdominal cramps. So this is the GI system. So this is important to know because, again, it's something different. Important fact is calcium gluconate is the antidote for a magnesium overdose. So when we look at EKG changes, we can see tall T waves and depressed ST segments for hypomagnesemia. And for hypermagnesemia, we can see shortened T waves and shortened ST segments and a widened T wave. If you don't need to memorize the EKG changes, most likely you won't be asked about that, but you will be asked about signs and symptoms. Risk factors for hypomagnesemia is insufficient magnesium intake. They could be malnourished, have celiac or Crohn's disease, vomiting or diarrhea, increased magnesium excretion through diuretics, alcoholism, hyperglycemia and insulin administration, or sepsis. For hypermagnesemia, they can have increased magnesium intake from antacids or IV magnesium. They can be in DKA or have renal insufficiency, so they have decreased excretion of magnesium. Our nursing interventions for hypomagnesemia is magnesium sulfate IV or PO, seizure precautions, and increasing magnesium-containing foods, which are avocado, leafy greens, milk, wheat, peanut butter, pork, beef, chicken, potatoes, and yogurt. For hypermagnesemia, we're going to give diuretics, IV administration of calcium gluconate, because we know that's the antidote, restrict intake of magnesium-containing foods, avoid laxatives or antacids that contain magnesium, and hemodialysis. And magnesium and calcium are the same, so when we have a high calcium, we also have a high magnesium. All right, let's talk about a phosphorus imbalance. So we have hypophosphatemia, which is less than 2.5, and we have hyperphosphatemia, which is greater than 4.5. Again, we're looking for differences. So cardiovascularly, hypophosphatemia will see decreased contractility and cardiac output with slowed peripheral pulses. For hyperphosphatemia, we'll see an increased heart rate early, but then it will turn to bradycardia that can cause cardiac arrest, and we'll have a bounding full peripheral pulse. So that is a difference. We can remember that. With respiratory hypophosphatemia and hyperphosphatemia, both have shallow respirations and ineffective respirations, so not much different there. When it comes neuromuscularly, again, we're not seeing huge differences. Rhabdomyolysis in hypophosphatemia, but they're both kind of showing absent or diminished deep tendon reflexes, weakness, so not much there to remember. But we will see in hypophosphatemia those central nervous system changes like irritability, confusion, and seizures, so that's important to know. And then in hyperphosphatemia, we'll see some gastrointestinal signs of decreased motility and hyperactive bowel sounds. Risk factors for hypophosphatemia are glucose administration or insulin release, respiratory alkalosis, milk absorption syndrome, diarrhea, vomiting, aldosteronism, and diuretic therapy. And risk factors for hyperphosphatemia are renal disease, hypoparathyroid or hyperthyroidism, excessive vitamin D intake, muscle necrosis, excessive phosphate intake, and chemotherapy. Nursing interventions for hypophosphatemia are neurological assessments and phosphate supplements as prescribed. And for hyperphosphatemia, assess for signs of hypocalcemia, teach patients to avoid foods and medications with phosphorus, administer phosphorus-binding antacids, and prepare patient for possible dialysis. Foods with phosphorus include fish, pumpkin, nuts, pork, beef, chicken, whole grains, and dairy. And calcium and phosphate are opposite. So if we have high calcium, we'll usually have a low phosphate. We just went over in depth with the free electrolyte study guide, but within this study guide, you have a more briefer overview of the main points of electrolytes. I'm not going to go through all this again. I included the electrolyte, but this is here in a less colorful form, so you can review these. And again, making sure to know what foods these are in. So let's talk about electrolyte relationships. So sodium and potassium have an inverse relationship. So a high sodium means that you're going to have a low potassium. calcium and phosphorus have an inverse relationship. So a high calcium is a low phosphorus, and magnesium and phosphorus have an inverse relationship. So low magnesium, high phosphorus. Calcium and vitamin D are the same. So a high calcium means a high vitamin D. Magnesium and calcium are the same. So a low magnesium, you're also going to see a low calcium. And magnesium and potassium are the same. So a low magnesium can also mean a low potassium. And again, here are just a review of those electrolytes. Okay, let's talk about acid-base balance. So we have two different manifestations. So we have acidosis and alkalosis. Now, within each manifestation, it can be respiratory or metabolic. It can be respiratory or metabolic. So these are the signs and symptoms we're going to see. So first, let's talk about acidosis. If it's a respiratory acidosis, we're going to see drowsiness, disoriented, dizzy, headache, or coma. And if it's a metabolic acidosis, we're also going to see drowsiness, confusion, headache, and coma. If we come over to alkalosis, for neurological, lethargy, lightheadedness, confusion, metabolic, drowsiness, dizziness, nausea, confusion. So all of these are very similar. So you don't need to go through each one and remember respiratory, I'm going to see this for acidosis. Metabolic, I'm going to see this for acidosis, because you're really seeing the same thing for almost all of these. We want to look at the differences. So one thing I see is metabolic alkalosis, nervousness. So that might be a key thing to remember. I'm also seeing that for acidosis, we may see a headache for both metabolic or respiratory. So that might be something to just remember. But now let's move down. So cardiovascularly, for respiratory acidosis, we're seeing decreased blood pressure, dysrhythmias, warm flushed skin. For acidosis metabolic, we're seeing decreased blood pressure, dysrhythmias, warm flushed skin. Again, same symptoms. So, okay, we don't have to really remember the differences with those. If we come over to alkalosis and we look at respiratory alkalosis, we're seeing tachycardia, dysrhythmias. For metabolic alkalosis, we're seeing tachycardia and dysrhythmias. Okay, so we can see with this one that how we can differentiate it is with acidosis, we're seeing a decreased blood pressure and dysrhythmias. So the main thing is the decreased blood pressure for acidosis. Both. It could be either, right? This isn't differentiating between respiratory and metabolic, but we're seeing decreased blood pressure. When it comes to alkalosis, the real difference that we're seeing is the tachycardia, and we could see that for metabolic or respiratory. So let's just remember that. Okay, so let's move along. So for respiratory acidosis, we're seeing no GI symptoms. For metabolic acidosis, we're seeing nausea, vomiting, and diarrhea. Okay, so that's important to know that those are some differences. Now, when it comes to gastrointestinal for respiratory alkalosis, we're seeing nausea and epigastric pain. When it comes to metabolic alkalosis, we're seeing anorexia, nausea, and vomiting. So this is supposed to say vomiting. Okay, there we go. I will fix that in the study guide. We can see that the difference, a key thing, is with respiratory alkalosis, epigastric pain. Okay, so let's remember that. Epigastric pain. Okay, so now let's move along to respiratory acidosis. So we're going to see neuromuscular, we're going to see seizures. That's important, so remember that. And then for metabolic acidosis, we have no neuromuscular symptoms. For respiratory alkalosis, we're seeing tetany, numbness, tingling of extremities, hyperreflexia, and seizures. So we need to remember all of these, right? Tetany, numbness and tingling, hyperreflexia. So this one is a key for respiratory alkalosis specifically, right? We don't see that for any of the other ones. And again, if we come over to alkalosis metabolic, we again have those tremors, hypertonic muscles, muscle cramps, technique, tingling, seizures. So these are the same. So just noticing that alkalosis, you're having a lot of those neuromuscular symptoms. All right, so moving along, respiratory acidosis for respiratory is going to be hypoventilation with hypoxia. Very important. This is different than our metabolic acidosis, which is going to have deep, rapid respirations or Kussmaul's. So these are different. So remember those. For alkalosis respiratory, we're having hyperventilation. Again, this is different. So remember this one. And for metabolic alkalosis, we're seeing hypoventilation. So you want to remember all the differences in respiratory for these. You can see a significant difference. For respiratory acidosis, the causes are asthma, electrolysis, brain trauma, central nervous system depression, pulmonary edema, COPD, and hypoventilation. For metabolic acidosis, our causes are diabetes, excessive ingestion of acetylsalicylic acid, high-fat diet, malnutrition, and diarrhea. For respiratory alkalosis, our causes are fever, hypoxia, hyperventilation, pain, and hysteria. And for metabolic alkalosis, our causes are diuretics, vomiting, hyperaldosteronism, ingestion of sodium bicarb, and a massive transfusion of blood. Our nursing interventions for respiratory acidosis are monitor signs of respiratory distress, administer oxygen, place them in semi-Fowlers, turn cough, deep breathe, and hydrate to thin secretions. For metabolic acidosis, our nursing interventions include monitor for respiratory distress, assess level of consciousness, monitor INO, monitor potassium, and if in diabetic ketoacidosis, give insulin. For respiratory alkalosis, our nursing interventions are to monitor for signs of respiratory depression, emotional support, assist with breathing techniques, and monitor electrolytes. And our nursing interventions for metabolic alkalosis are monitor signs of respiratory distress, monitor ABGs, potassium and calcium, IV medications, and replace potassium. All right. Now let's talk about interpreting arterial blood gas results. So key points. In acidosis, the pH is decreased less than 7.35. In alkalosis, the pH is elevated, greater than 7.45. Respiratory function indicator is the CO2, and a metabolic indicator is the HCO3. Okay, so important to note that we know that a normal pH is 7.35 to 7.45. So if we go below that, we're in acidosis, and if we go above that, we're in alkalosis. Okay. So again, here's our normal values over on the right side for all of these. The thing that's nice is our pH is 7.35 to 7.45, and our CO2 is 35 to 45, so it's the same. HCO3 is 24 to 26, so you do have to remember that. And our PaO2 is 80 to 100%, we know that, and our SaO2 is greater than 95. Okay, so let's talk about the steps to interpret arterial blood gases. So step one, we're going to look at the pH. So this is step one. Is it high or low? And again, we just talked about if it's low, it's acidosis. If it's high, it's alkalosis. Okay, step two, look at the CO2. Is it high or low? What is the relationship to pH? So opposite relationship, one is high and the other is low, means a respiratory imbalance. A same relationship, both high or both low, go to step three. So a way to remember this is something called ROME. And this stands for respiratory, opposite, metabolic, equal. Okay, so if it's opposite, it's respiratory. If it's the same, we're going to go on to step three. Most likely metabolic, but there is a thing that it is not always metabolic. All right, so we're going to look at the HCO3 and what the relationship is to the pH. So if it's the same, both low or both high, it's a metabolic imbalance. All right, so let's move on to step 4. So if the pH is normal, but other things are not normal, it could be due to something called compensation. And that means that the body adjusts and compensates with other things to make the pH normal. So partially compensated is if the pH is not normal, we look at the system that is supposed to fix the problem. So if the condition is a respiratory imbalance, look at the state of HCO3 to determine the state of compensation. If the condition is a metabolic imbalance, look at PaCO2 to determine the state of compensation. What this means in a equation format is that a low pH plus a high CO2, respiratory acidosis, because we have a low pH, we know it's acidosis, and we have a high CO2, so we know that it's respiratory. A low pH plus a low HCO3 is metabolic acidosis. So again, we are looking at, because we know that if we follow Rome, respiratory opposite, so we can see low and high is opposite, and then a low and low is equal, so metabolic equal, so we have a metabolic acidosis. If we have a high pH and a low CO2, we're opposite, right? Low and high, so we know it's respiratory alkalosis, and a high pH plus a high HCO3, we know metabolic equal, so we know metabolic is equal, so it's metabolic alkalosis. All right, let's look at pharmacology. So this is a pharmacology review. This is a very kind of brief overview of different meds we learned in nursing school. If you want a more in-depth overview, something you can make flashcards with and really study these medications, I recommend getting the pharmacology study guide that you can actually print out different flashcards and things like that. But this is going to be an overview of you're getting ready to take your exam. You don't want to study like 100 note cards, etc., or 50 pages of information. So this is a 6-page pharmacology summary. All right, so first we have antacids. So these decrease gastric acidity, protect the stomach mucosa, and decrease epigastric pain. The mechanism of action is that it binds to excessive acids. Drugs include magnesium, aluminum hydroxide, or Maalox. Our side effects we're looking for are constipation due to the aluminum or diarrhea if it is a magnesium form. Nursing interventions avoid food that cause GI distress and don't overuse. Then we have antidiarrheals. So these decrease diarrhea. Mechanism of action is that it decreases motility, causes more water to be absorbed by the large intestines. Drugs include Lomotil and Imodium. Side effects include tachycardia, respiratory depression, urinary retention, dry mouth, respiratory depression. Nursing interventions include monitor fluids and electrolytes. Then we have antibiotics. So these decrease or destroy microorganisms. Mechanism of action depends on the class of drugs. So we have no glycosides. These decrease protein synthesis, things like gentamicin. We have cephalosporins, which bind to the cell wall, causing death. These are things like cefazolin. We have fluoroxyquinols, which decrease DNA synthesis, things like Cipro. We have macrolides, which decrease protein synthesis, things like Zithromax. We have penicillins, which bind to the cell wall and cause death, things like amoxicillin. We have sulfonamides, which decrease protein synthesis, things like Vibromycin, and we have anti-infectives, which decrease protein and DNA synthesis, and these are things like Flagyl. Our side effects include hypersensitive reaction, rash, or anaphylaxis, and our nursing interventions include culture and sensitivity should be done before initiating antibiotic therapy, and teach the patient to take entire prescription, monitor for hepatotoxicity, and nephrotoxicity. All right, now let's talk about anticoagulants. So these interfere with normal coagulations, leading to decrease in thrombus formation or extension. Mechanism of action depends on the type we're using again. So we have thrombin inhibitors, which decrease conversion of prothrombin to thrombin and conversion of fibrin to fibrin, fibrogen to fibrin. These are things like heparin. Low molecular weight heparins block coagulation factor XA. These are things like Fragmin or Lovenox. Then we have clotting factor inhibitors. These interfere with vitamin K synthesis. These are things like warfarin. And we have platelet inhibitors, which decrease platelet aggregation, and these are things like Plavix. So our side effects include excessive bleeding, bruising, melena, which is dark stools that have blood in them, epistaxis, which is bloody nose, bleeding gums, low hemoglobin, thrombocytopenia. Our nursing interventions are to monitor PT, INR, and monitor for bleed. All right, then we have antiemetics. These decrease nausea and vomiting and prevent and decrease motion sickness. Mechanism of action is a 5-HT3 antagonist, which blocks serotonin at the receptor site in the vagal nerve terminals and chemoreceptor trigger zones in the central nervous system. These are drugs like ondansetron or Zofran. Side effects include headache, dizziness, constipation, diarrhea. And our nursing intervention is to give 30 to 60 minutes before chemotherapy and to teach the patient to avoid alcohol. Then we have antifungals. These decrease fungal growth. It does this through impairing the fungal plasma membrane. Drugs include Miselex and Neostatin. Side effects, we look for renal, liver, and ototoxicity. It can be teratogenic, nausea, vomiting, and diarrhea. This is important. Nursing interventions include teaching the patient to complete the entire regimen. Then we have analgesic or antipyretics and NSAIDs. The mechanism of action, again, depends on the drug. So we have analgesics. They inhibit prostaglandins involved in pain and fever. These are things like Tylenol. Then we have NSAIDs, which inhibit prostaglandins involved in inflammation, pain, and fever. These are things like ibuprofen or naproxen. Side effects, we're looking for hepatic toxicity, rash, tinnitus, and flu-like symptoms. Nursing interventions, it's important to know that you do not exceed 4,000 milligrams of Tylenol per day. Monitor for GI bleeding and avoid alcohol. Then we have anti-Alzheimer's medications. These decrease signs of dementia. Mechanism of action is increasing acetylcholine levels. Drugs include donepezil and glantamine. Side effects are anorexia, nausea, vomiting, headache, dizziness, insomnia. And our nursing interventions are to teach the patient and family that this medication is not a cure and use caution in COPD patients. Then we have antidepressants. So these are going to lift a depressed mood. Their mechanism of action depends on the type. So we have TCAs, which decrease the reuptake of norepinephrine and serotonin in the presynaptic nerve terminals. These are things like Elavil or Pamelor. We have SSRIs, which decrease reuptake of serotonin in the presynaptic nerve terminals. These are things like Celexa, Prozac, Paxil, and Zoloft. We have MAOIs, which decrease the breakdown of norepinephrine, dopamine, and serotonin. These are things like Nardil. And we have atypicals, which increase the effects of dopamine, serotonin, norepinephrine. These are things like buprenorphine, Remeron, or Effexor. If you guys want a more detailed overview of antidepressants, I do have a whole discussion on that on the YouTube channel. So side effects include anticholinergic effects, sexual dysfunction, dizziness, headache, weight gain, increased appetite. Our nursing interventions are to assess for suicidal ideation, high risk because medications give patients more energy to commit the act. Medications need to be used for 2 to 6 weeks to start to see the effects. Monitor for serotonin syndrome. These are going to be things like the patient is really hot, they have dilated pupils. Do not stop the medication abruptly. And for TCAs, do not give to a patient with narrow angle glaucoma. And for MAOIs, avoid food with tyramine. So this one is very important. All right, let's talk about antidysrhythmics. So these decrease abnormal electrical conduction in the heart. Mechanism of action, again, depends on the drug. So class 1, calcium ion antagonists, these slow conduction used for ventricle dysrhythmias. These are things like Procambid or lidocaine. We have class 2 beta-adrenergic blockers, which decrease cardiac excitability, output, and workload, decreases heart rate and blood pressure, things like metoprolol. Class 3, we have potassium channel blockers. These slow the heart rate and conduction. It's used for ventricular and supraventricular dysrhythmias, things like amiodarone. In class 4, we have CCBs, so these are calcium channel blockers, decrease entry of calcium into the myocardial cells, decreases SA and AV node conduction, and used for AFib and SVT. These are things like verapamil and dilazestrant. Side effects include heart failure, hypotension, anticholinergic effects, diarrhea, and new dysrhythmias. And our nursing interventions are to monitor heart rate before administering and do not give if heart rate is less than 60. This is very important. You may get a question about that. So now let's talk about antihistamines. So these decrease the sign of an allergy. They do this by blocking histamine and decreasing allergic reactions. Side effects include dry eyes and mouth, constipation, blurred vision, and sedation. Our nursing interventions are that they're contraindicated in narrow angle glaucoma, and we want to administer with food to decrease GI irritation. Gum or hard candy can help with a dry mouth. Then we have antihypertensives. So these decrease blood pressure. Their mechanism of action depends on the type. So we have ACE inhibitors. These decrease the release of aldosterone, which increases the excitation of sodium and H2O. These are things like enalapril, lisinopril, or ramipril. So a lot of these end in pril. Then we have calcium channel blockers, which these cause relaxation, dilation of vascular smooth muscle of coronary arteries. These are things like amlodipine, dilatazem, nifedipine. A lot of these end in penes. Some of them don't, though. Obviously, this one. Angiotensin II receptor blockers. These decrease vasoconstriction and decrease the release of aldosterone. These are things like Avapro, losartan, valsartan. A lot of these end in sartan. That's how you can remember these. Then we have beta blockers. We have selective, which blocks stimulation of beta-1 myocardial receptors. These are things like metoprolol. A lot of beta blockers end in lol. We also have beta blockers non-selective, which blocks stimulation of beta-1 and beta-2. So this is pulmonary receptors and myocardial. And these are things like Carvedal or labetalol. Side effects include dizziness, weakness, flushing, and bradycardia. Nursing interventions is that abrupt withdrawal can lead to hypertension and dysrhythmias, so we don't want to abruptly stop them. And we want to assess for increased fluid volume, monitor blood pressure, and heart rate. Right. Then we have antilipidemic. These decrease LDL, triglycerides, and total cholesterol, and they increase HDL, which is the good cholesterol. Mechanism of action depends on the type. So we have an HMG-CoA reductase inhibitor, which inhibits this HMG-CoA enzyme, which is a catalyst in the synthesis of cholesterol. These are things like atorvastatin, rosuvastatin, and simvastatin, and a lot of these again end in statin. Then we have bile acid sequestrants. So these bind to cholesterol, inhibit absorption of cholesterol in the small intestines. These are things like cholestyramine and ezetimibe. Sorry, I don't know how to say all of these. Side effects include nausea, vomiting, abdominal cramps, diarrhea, constipation. And nursing interventions are they need to avoid grapefruit juice with HMG-CoAse reductase inhibitors because it will increase toxicity. So it's important. All right, now we have anti-neoplastics. These destroy and decrease the growth of neoplastic cells. Mechanism of action depends on the type. So we have alkylating agents which decrease DNA synthesis and prevent replication. These are things like carboplatin or cisplatin. We have antimetabolics which decrease DNA synthesis and metabolism. These are things like ferroxyuracil or methotrexate. Our side effects include renal, GI, and skin problems, nephrotoxicity, ototoxicity, and alopecia. Our nursing interventions are to teach patients about alopecia as a side effect, do period blood tests throughout to monitor their levels, protect patients from infection, and provide frequent meals. These are immunosuppressives. All right, then we have anti-Parkinson's drugs. These balance dopamine and acetylcholine. Mechanism of action depends on the drug type. So we have a dopaminergic, which increases dopamine. These are things like amantadine, bromocysteine, and carbidopa-levodopa. Then we have anticholinergics, which decrease excessive cholinergic activity. These are things like cogentin. Our side effects are hypotension, increased heart rate, fatigue, nausea, vomiting, dry mouth, constipation, muscle twitching can be a sign of toxicity. It's important to know. Nursing interventions do not stop abruptly, and it can cause a Parkinsonian crisis if you stop them abruptly. Then we have antipsychotics. These decrease hallucinations, psychotic symptoms, and decrease agitated behavior. Mechanism of action, again, depends on the type. We have typical for positive symptoms like Haldol or prochlorpazine. Then we have atypicals, which are for negative symptoms and positive symptoms. These are things like Clozaril, Zyprexa, Seroquel, and Risperdal. Side effects, we're looking for extrapyramidal side effects. So these are things like dystonias, akathisias, Parkinsonian symptoms, tardive dyskinesia, sedation, hypotension, sexual dysfunction, and anticholinergic effects. Our nursing interventions is that it can take 2 weeks to see results. Increase fluid and fiber to avoid constipation, avoid caffeine, monitor for those extrapyramidal symptoms, and give meds to help with those extrapyramidal symptoms. We can give things like cogentin. Then we have anti-secretory agents. These decrease gastric acidity and improve pain. Mechanism of action depends on the type. We have H2 antagonists, which decrease histamine at the H2 receptor in the parietal cells and decrease gastric secretions. These are things like Pepcid or Zantac. We then have proton pump inhibitors, which decrease the entry of hydrogen ions in the gastric lumen. These are things like Prilosec, Prevacid, and Protonix. Side effects are confusion, dizziness, drowsiness, headache, nephrotoxicity. And our nursing interventions are to administer 1 to 2 hours before or after antacids. They may increase anticoagulant effects of warfarin and do not crush proton pump inhibitors. Now we have anti-seizure medications. So these decrease the severity, frequency, and occurrence of seizures. Mechanism of action depends on the type. Some of them will block sodium channels, inhibiting action potentials. These are things like Tegatrol or phenytoin. Then we have analog of GABA, but does not act on the GABA channels. Mechanism of action is unknown. These are things like gabapentin. Then we have another one that blocks sodium channels and high voltage dependent calcium channels like Lamictal or Topamax. For Keppra, our mechanism is unknown but used for focal onset myoclonic and tonic-clonic seizures. Phenobarbital enhances the inhibitory effect of GABA-mediated neurons. And valproic acid blocks sodium channels, GABA channel transaminase, and T-type calcium channels. Side effects we're looking for include dizziness, drowsiness, nausea, vomiting, headache, hypertension, respiratory depression. Things we want to look for that are important to know. So phenytoin, we want to look for ataxia and gingival hyperplasia. Nursing interventions include increase dose gradually, provide oral care, avoid alcohol and other CNS depressants, and do not abruptly stop as it can lead to seizures. The next one is antitubercular. So these are used in tuberculosis. They decrease cough, fever, and night sweats. Mechanism of action is to decrease mycobacterial cell wall synthesis. Drugs are isoniazid, rifampin, ethambutol. Side effects are peripheral neuropathy, hepatotoxicity, diarrhea, and optic neuritis. Nursing interventions are to avoid aluminum-containing antacids for 1 hour before or after medication dose, and educate patients that rifampin will produce orange-colored urine. This is important to remember. All right, then we have antivirals. So these prevent or decrease the severity of a viral infection through decreasing viral DNA synthesis or entry of the virus into the host. Drugs are Tamiflu or acyclovir. Side effects: anorexia, nausea, vomiting, diarrhea, headache, vaginitis. Nursing interventions are culture and sensitivity needed before giving medications. Then we have analytic, sedatives, and hypnotics. These decrease anxiety, help with sleep, and ease alcohol withdrawal. Our mechanism of action depends on the type. So we have diazepines, which increase the action of GABA inhibitory neurotransmitter. We have short-acting like Xanax, medium-acting like Ativan, and long-acting like Librium, clozapam, or diazepam. Then we have non-barbiturates, which CNS depressant effect. So these are things like Buspar, Benadryl, or Ambien. Side effects include decreased mental alertness, hypotension, dizziness, headache, euphoria. Nursing intervention, our benzodiazepines can create dependency and to avoid alcohol and caffeine. Then we have bronchodilators. So these promote bronchial expansion, allow for gas exchange, and decrease shortness of breath. Mechanism of action depends on the type. We have xanthines, which relax bronchial smooth muscle and decrease spasms like theophylline. We have anticholinergics, which decrease the action of acetylcholine receptors in bronchial smooth muscles, so like Atrovent. We have leukotriene receptor antagonists. So these decrease edema, bronchoconstriction, and inflammation. These are things like Singulair. We have inhaled steroids, which decrease local inflammation response and edema, increase airway diameter. Things like Pulmicort or Flovent. Side effects include increased heart rate, decreased blood pressure, palpitations, dizziness, headache, weakness, dry mouth, urinary retention. Nursing interventions: use bronchodilators first, then wait 1 to 5 minutes between inhalers, rinse mouth after use, and encourage fluid intake to avoid dry mouth. So this is important. Inhalers and rinse the mouth. Okay. Now we have cardiac glycosides. So these increase the force of contractions, decrease heart rate, and increase cardiac output. Mechanism of action: inhibits sodium, increases cardiac intracellular calcium, increases myocardial contractility. These are things like digoxin. Side effects are low heart rate, drowsiness, fatigue, and weakness. Nursing interventions include: give a loading dose first, assess atypical pulse before giving medications, heart rate must be greater than 60. So this, you may be asked if you're giving a patient on digoxin about their heart rate. It has to be above 60. The therapeutic range is 0.5 to 2, and first signs of toxicity are usually GI related. It's important too. So then we have cardiac stimulants. So these increase heart rate. They stimulate alpha and beta receptors to increase the heart rate and contractility. These are drugs like atropine, sulfate, dobutamine, norepinephrine, or ephedrine, or epinephrine. Side effects are dysrhythmias, increased heart rate, headache, anticholinergic effects. Nursing intervention are continuous EKG when giving them IV. Then we have coronary vasodilators. So these dilate arteries, decrease preload and afterload, decrease myocardial oxygen consumption. Mechanism of action: they block calcium channels and relax smooth muscles to treat angina and hypotension. Drugs are things like amlodipine, Procardia, nitroglycerin, verapamil. Side effects are orthostatic hypertension, increased heart rate, headache, dizziness, nausea, vomiting, flushing. And our nursing interventions are to wear gloves when we put it on, put oral nitro under the patient's tongue, and avoid sudden standing. Then we have diuretics. So urine output, decrease hypervolemia and decrease blood pressure, decrease edema, and decrease intracranial pressure. Mechanism of action depends on the type. We have thiazide, which decreases sodium and chloride reabsorption in the distal convoluted tubule and decrease chloride reabsorption in the loop of Henle. These are things like hydrochlorothiazide or metrolazone. Then we have loop diuretics, which decrease sodium and chloride reabsorption in the ascending loop of Henle and distal tubules. These are things like Lasix or Bumix. We have potassium sparing. These in the distal tubules decrease action of aldosterone. Sodium is excreted, but it retains potassium. These are things like aldactone. So this is important to know what is a potassium sparing specifically, and then what is not, because you may get a question about that. Side effects are things like dehydration, orthostatic hypotension, decreased potassium, except with potassium sparing, fluid and electrolyte imbalance. Nursing interventions, we want to monitor potassium levels. Given the morning due to patients urinating, it could keep them up at night, and change positions slowly. Then we have hypoglycemics. So these mechanisms of action depends on the type. So we have sulfonylureas, which stimulate beta cells to release insulin. These are things like amaryl, glipizide, glyburide. Then we have bigurides, which increase sensitivity to insulin, increases binding of insulin at the receptor. These are things like metformin. And then we have meglitides, which increase the release of insulin in the pancreas. And these are things like repaglinide. Side effects are hypoglycemia. Nursing interventions are contraindicated in type 1 diabetes and monitor for hypoglycemia. Then we have laxatives, which relieve constipation. Mechanism of action depends on the type. We have bulk forming, which increases the bulk and stimulates peristalsis. These are things like Spilium. We have stool softeners, which water and fat enter the feces to soften and decrease drying of stool. These are things like Colace. We have stimulants, which can irritate. These are a rapid propulsion of continence. So these are things like Duralax or Senecot. And then we have saline osmotic, which draws water in and stimulates peristalsis. These are things like milk of magnesia and sodium phosphate fleet. Side effects are cramps, fluid and electrolyte imbalances. Nursing interventions is contraindicated if vomiting, nausea, or abdominal obstruction. We want to give at bedtime, encourage fluids, and saline osmotic is the most rapid acting. Then we have opioids. So these decrease transmission of the pain impulse. Mechanism of action is combined with opioid receptors in the CNS. Drugs are codeine, fentanyl, hydrocodone, hydromorphone, methadone, morphine, oxycodone. Side effects is they decrease the respiratory rate. They can cause sedation, constipation, nausea, drowsiness. Nursing interventions are to monitor for respiratory depression and have naloxone available, which is Narcan, and it is the reversal agent. Then we have opioid antagonists. So these reverse opioid-induced respiratory and CNS depression. Mechanism of action is to deplace opioids at respiratory receptor site by a competitive antagonism. Drugs is naloxone or Narcan, so that's what we were just talking about. Side effects are nausea, vomiting, and VFib. Nursing interventions are monitor for opioid withdrawal. If given for patient with pain, all of pain relief will be reversed and patient will feel pain. So just be prepared for that. If you would like a copy of the study guide, you can find it on my website, blossom with jessica.com.